Is everybody sleepy after lunch? All those who are sleepy, raise your hand. Okay, you're not allowed to fall asleep. We're gonna start off this afternoon. We're gonna go back, if you have your agenda, we're gonna go back and take public comment on the things we've talked about this morning, beginning with the vulnerable adults, transportation. We'll start with those things. We'll take any public comment on those to start with. So if you would like to speak to the group, please come forward. Identify yourself. And Chairman Larson is not asleep. He will be back. Or he might be asleep. I don't know. There's no easy way up here, is there? It's a long ways around. You could have just jumped over him. Go ahead and introduce yourself and address the committee.
Good afternoon now. I'm Emily Smith, the Director of Wyoming Guardianship Corporation, and I had just some comments. Hopefully, thank God I have notes because I feel like it's been 7 hours since we talked about this, but for the committee. So Chairman Baldwin, I guess I just wanted to start with that. And this is specifically about guardianship, which is my area of expertise. But people who need a guardian are a very high-risk subsection of vulnerable adults. So, for the people listening in, not everybody who is vulnerable needs a guardian, but everybody who needs a guardian is a vulnerable adult. So just that piece, get that out of the way. But I know that there was some questions about some of the ARPA funding that Wyoming Guardianship is collaborating with the Department of Family Services on, and Director Schmidt and Elisa were accurate in their responses to the questions, but I wanted to elaborate just a little bit, and then if anybody had questions for me, this would be a great time. So the funding that we have for guardianships with the Department of Family Services paid for guardianship services for 20 people. And it also paid for legal fees and guardian ad litem fees for those 20 people because guardianship is a legal process and you can't get a guardian without going to court. So a lot of times where the process gets stymied is getting into the court in the beginning. So without the funding to get into the court, you have a problem. So the funding included all of that. So hopefully that makes sense and I can elaborate on that if I need to. And Elisa was also very correct. The courts in Wyoming do not pay at all for guardianship. That's not necessarily true in other states, but it is true in our state. And so what happens usually is if someone needs a guardian, there's a petitioner. It depends on, who's involved with the case, who that petitioner is. The petitioner usually obtains an attorney. The attorney files the petition, they write the petition, and in the petition it says, this person should be the guardian. And, in Wyoming, as with most states, we have a statutory obligation to make sure that nobody else in the community is available to provide that service. Professional guardians are a last resort. There's a long list in the statute that says these are the people who should be someone's guardian. Professional guardians are at the very bottom. So we are looking, and DFS is looking, and whoever's involved in the case is looking for all those people that might be involved with the individual, the vulnerable individual, before they come to Wyoming Guardianship. And so when you file that petition, you would have that person in mind already. The petition typically says, and this is the person we're proposing be the guardian. So I would say that a lot of times, and this is not a good answer for Speaker Summers, but a lot of times if you can't find somebody to be the guardian, frankly, my belief is that you just don't get the petition filed. I think those people, no one files that petition because they can't figure out who the guardian's going to be. So their petition is incomplete. However, over the years, sometimes a judge may call me and say, this case is in front of me, please do this. I think that Chairman Larson maybe said bullying, but if the judge calls you and asks you, just say yes, whether you're bullied or not. So sometimes that does happen, but my concern is that most of these folks, it probably never gets to the court's eye anyway, because there is nothing to write into the petition. So hopefully that answered a couple of those questions from this morning. And if you all have questions, I'd be happy to try to answer those for you.
Questions committee. I have one real quick.
Yes.
Just involving, as a medical provider, sometimes I have to fill out the medical necessity. And the person is unable to take care of their own affairs, et cetera, and then they go on to this one that's in my mind is to the guardianship corporation. How often are those medical releases challenged, or do they fail? Or do they say, no, this isn't evidence enough? Does that happen?
Chairman Baldwin, that's a great question. I've been doing this for a long time, so about 15 years specifically. And I don't know that I would say those have been challenged maybe only in one or two instances. Most of the time, the medical providers, we have great medical providers in Wyoming, and those folks either have written a very detailed letter or they're actually in court providing testimony. And you know, they're very competent, those folks, and our judges tend to believe what they're asking. So.
Very good. Further questions, committee members? Online committee members? Senator Barlow's running away. Mr. Speaker, I thought you had a question on your lips. I guess not. Okay, thank you very much.
Thank you, committee.
Any further public comment on anything we talked about this morning? Come on up. It's a long ways around, so it's good to get a head start. Welcome. Go ahead and introduce yourself and address the committee, sir. Just push it. The green light should light up. There you go.
My name is Ahmed Sheikh. I'm a resident of Laramie, born and raised. I came here to this meeting to kind of get a feel for what the state's looking to do for our vulnerable adults. I work for my family's home health agency. We've been in business since 2001. And during that time, it seems like over the years, there's been a lot of regulatory and red tape put in place that is affecting the quality of care that a home health aide can deliver to a vulnerable adult, such as an elderly person, somebody who's disabled or suffering from chronic illness. You know, a lot of the topics discussed this morning really could be solved through the state's home health agencies. You know, I know our staff provide meal preparation. We do grocery shopping for these individuals. Most of them are homebound. And I feel that, you know, the process for getting somebody started on our services is very lengthy, and there are gaps where this individual can't get groceries. They can't get a shower. They can't, you know, do these daily living tasks by themselves. So I really think that the committee should consider the avenues that home health agencies can provide some of the remedies to these issues facing our state.
Very good. Before there's any questions, thank you for coming to the committee. We appreciate not very many people in the state come to the committee and testify and get up in front. It's a nerve-wracking thing to do, even the people that do it all the time. So thank you very much for coming.
Yes.
So with that, are there any questions, committee?
Mr. Chairman.
Go ahead, Mr. Chairman.
Mr. Chairman, I just made a note of that because that's really an important component of this whole delivery. And, you know, maybe we'll follow up a little bit as we come back, and I just want to follow up, make sure I understand the process a little more. So thank you.
Very good. Further questions?
Mr.
committee?
Chairman.
Go ahead, Speaker Summers.
Mr. Chairman, thank you. Really not a question. I just really appreciate the comments, and I really do think we need to look to see whether we can do more to keep people in their homes that are vulnerable adults, whether those are, no matter what their age are. And I think we just need to track that track that out and see what we've done and what we can do. So I do appreciate the comments. Thank you.
Noted. Thank you, Mr. Speaker. Go ahead, Director.
Thank you, Mr. Chairman, and thank you for your testimony. I'm just curious, if you're not comfortable answering me, then please don't. But what are the payer sources that you bill to provide those services to those families?
Our main, payer is Wyoming Medicaid through the Home-Based and Community Waiver Program. We also do accept private pay, but, that's kind of mostly, retired professors from the university or whoever, but, I would say 90% of our clients are, on the Medicaid program.
Further questions? Seeing none. Thank you very much for coming down. We appreciate your testimony. Further comments, questions in the room? We'll talk about that in just a minute. Okay, nobody online? Okay. That, yeah.
I can explain that.
Mr. Co-Chair, let's move to that subject right now and we can deal with that on the dementia discussion.
So, and we want to hear any thoughts you have on that today, but the dementia discussion came to us from former Speaker Tom Lubnow, who suggested we may want to consider some statutory changes in our, what was the term I'm looking, which directive was that, Anna? In the advanced directive. And so we looked at, we researched the statutes, and we thought that the LFSO staff and I thought that the statutes kind of allowed for that. His Speaker Lubnow suggests that maybe we're missing some points of that, and was going to get back with us with some reference and some suggested language. And so we're going to kind of hold off on pursuing that pending, because he does a lot of work in that area, pending his recommendation. But Mr. Chairman, if we've got somebody here that would like to address this and help us understand this better, it would be very helpful.
Come on down. Welcome to the front row. Go ahead and introduce yourself, and the best students always sit in the front row, That's what I've heard. Yeah, go ahead and push that button and get a green light and then introduce yourself.
Good afternoon, Chairman Larson and Chairman Baldwin and all the Mental Health and Vulnerable Adult Task Force. My name is Ann Ackwin. I'm a longstanding volunteer with the Wyoming chapter of the Alzheimer's Association and a member of their board. I lost both my parents to Alzheimer's disease. Our director, Deborah Antista Bianchi, really wanted to be here today to speak with you directly, but she is in Philadelphia attending the Alzheimer's Association International Conference, which is telling her all the good science that's happening right now. So have to forgive her for that. I want to thank you for the opportunity to comment and give you some background information on Alzheimer's and dementia related to the agenda entitled Dementia Directive Discussion. Dementia is an overarching or umbrella term that refers to a range of symptoms affecting an individual's cognitive abilities. Alzheimer's disease is a specific, the most common type of dementia, which is characterized by progressive memory loss and cognitive decline. Alzheimer's disease and other forms of dementia affect everyday activities of daily living and progressively worsen multiple cognitive skills such as judgment, visuospatial ability, language, memory, and/or personality. As you know, dementia can cause enormous suffering and financial costs. It's been declared by the CDC as a public health crisis. It's important to recognize the unique nature of dementia. A common mistake is to think that dementia is a mental illness due to the effects of the condition has on the brain. There are distinctions, however, that should be made between dementia and mental illness. While dementia does affect mental health, it's not a mental illness, but rather a degenerative disorder of the brain that causes memory loss and trouble with communicating. Misdiagnosis of mental illness in seniors can occur easily since symptoms can be similar to dementia. Just as someone with a mental illness or substance use disorder may become self-injurious, aggressive, or violent towards others, a significant percentage of individuals with dementia will exhibit these behaviors during their disease progression. While dementia manifests differently in all individuals, it's an irreversible and fatal condition, and it impacts 1 in 3 seniors in America. Conversely, with a proper diagnosis, mental illnesses are or can be treatable, and the management of symptoms can return individuals to a normal lifestyle. It's imperative that Wyoming recognizes the difference between dementia and mental illness and addresses the unique nature of the degenerative brain disorder when addressing vulnerable adults in the state. Individuals living with Alzheimer's and other forms of dementia are also among our society's most vulnerable citizens. First responders, including law enforcement, firefighters, emergency medical technicians, and adult protective service workers, interact with individuals who have Alzheimer's or other forms of dementia in a variety of settings. 6 in 10 people with dementia will wander. My mom was one. And a person with dementia may not remember their name, address, or even family members. When individuals with dementia wander and become lost, they may show signs of anxiety, fear, or outright hostility, all of which can escalate to even more aggressive behavior. The escalation of aggressive behavior is not limited to wandering events, as persons with dementia can become disoriented, confused, and aggressive, even in familiar places when surrounded by family and caregivers. Older adults with dementia are particularly vulnerable to abuse, but the connection between elder abuse and dementia is often missed due to insufficient knowledge and inadequate education and training for people who work with older adults who have dementia. Abuse of older adults with dementia is significantly underreported because the detection of abuse is often complicated by various biological, pathological, ethnic, and cultural factors. Recent studies have shown that nearly half the population with dementia experience abuse or neglect. One study has estimated that only 1 in 24 cases of abuse are actually reported to authorities. Caring for a person with Alzheimer's or another dementia also poses special challenges. Individuals with dementia require increasing levels of supervision and personal care as the disease progresses. As a person with dementia's symptoms worsen, caregivers can experience increased emotional stress and depression, new or exacerbated health problems, and depleted income and finances due to part to disruptions in employment and paying for health care and other services, both themselves and the person living with dementia. Dementia caregivers report higher levels of burden and stress, depression, or other adverse mental health outcomes, strain, and problems with navigating care transitions when compared with other caregivers or non-caregivers. A full 59% of family caregivers of people with Alzheimer's or other dementias rated the emotional stress of caregiving as high or very high. Dementia caregivers often delay or forgo their own health and well-being, as a 2017 poll found that 27% of dementia caregivers delayed or did not do the things that they should to maintain their own health. 74% of dementia caregivers reported that they were somewhat concerned or very concerned about maintaining their own health since becoming a caregiver. Compared with caregivers of people without dementia, caregivers of those with dementia indicate more substantial emotional, financial, and physical difficulties, with the prevalence of anxiety among dementia caregivers at 44%. Finally, and most concerning, a systematic review found the prevalence of suicidal ideation, thinking about making plans for suicide in dementia caregivers, is exceptionally high. While an exact age comparator is not available, the prevalence of suicidal ideation in dementia caregivers with a mean age of 64 is 32%, compared with 2.7% of adults age 56 or older who are not caring for someone with dementia. As Wyoming works to address mental health issues and protect our state's vulnerable adults, we must ensure that persons living with Alzheimer's and all related dementias are prioritized. People living with dementia deserve a state that not only understands the unique nature of the disease, but also works to create a dementia-capable environment with dementia-specific support and services. The Wyoming chapter of the Alzheimer's Association stands ready to work with the state of Wyoming and the Mental Health and Vulnerable Adult Task Force to make this a reality. And just sort of give you an idea of some of the statistics, there's over 10,300 people in the state of Wyoming that have been diagnosed with Alzheimer's. That is estimated to be way under what's really there, possibly as much as half. And for those 10,300 people diagnosed, there are 16,000 unpaid caregivers. And my understanding from a conference I attended 3 years ago, approximately 18% of those caregivers are under the age of 18. Our children are caring for their grandparents, and they're accepting the responsibility of this. So it's a huge problem, and we hope that the task force will definitely take them into consideration in what you're working towards.
Thank you very much for that. Before he pontificates, I get to pontificate. And I would say thank you very much. And I think you just spent whatever, 10 minutes giving a lecture that I give my patients at least once a week or more. And the big thing that struck me was the percentage of caregivers that neglect their own personal health. That's very, very, very common. And that pays consequences down the road. So that's a really big deal. And I would add to that, a lot of dementia and Alzheimer's gets covered and gets blown off, if you will. And I will tell you, I make fun of my mother-in-law all the time because she forgets a lot. She doesn't have Alzheimer's, I don't think. But I think a lot of that happens. I think that, and I knew a gentleman that went to the grocery store, came out of the grocery store and went to the wrong car and couldn't figure out why he couldn't start it. Called the police, et cetera, and we found out it's not your car. And that turned out to be early Alzheimer's. So I think it gets blown off a lot. And we laugh about people that forget their car keys and their phones and or whatever. It's important, and I think it's something that we'll talk about down the road. Certainly we'll be talking about this again with Speaker Lubnow, but I think it's something that don't stop what you're doing. I know Walk to End Alzheimer's is one of my favorite events of the year. This year I don't get to go to, but it's a big deal. So keep up the good work and do what you're doing. Now with that, we'll let the co-chairman speak.
Thank you, and just appreciate you bringing this and delineating the difference between mental health and dementia. And we realize that people who have mental health issue can also develop dementia, and that dual diagnosis becomes even more complicated for the caregivers to do. And I think just to help reassure you just a little bit, that's one of the reasons the task force is called a mental health and vulnerable adult, is because we're trying to include all of these issues that our society is facing with the mental challenges that we seem to be, whether it be on the dementia side or on a mental health side. So thank you for bringing and in speaking to us today. And we hope that our effort is to always have that in consideration, because it's something that I think all of us know somebody or is caring for somebody that's dealing with that right now. So thank you for being with us today.
Further questions, comments, committee? Online? See none. Thank you very much for coming today. We appreciate it. Okay, committee, we're almost up to our 9:30 subject now. We're actually covered part of our 9:30. We're going to take public comment. We're going to move ahead with public comment. We're going to talk about the bar model and everything you see on if you have an agenda in front of you, the K-12 mental health services. Do we have any public comment about anything that we talked about? Nobody's
So
jumping up.
Mr. Chairman,
What?
we do have Dr. Corso online.
Let's go ahead and bring him in.
Good afternoon, Chairman, committee members. Can you hear me okay?
Yeah, welcome, Dr. Corso. Go ahead and introduce yourself again. We all know who you are, and you're in a
Thank
much
you.
nicer place than we are right now. But
This
go
is
ahead,
my
sir.
tropical office. Thank you, sir. Good afternoon. My name is Dr. Corso. I'm a clinical psychologist, board certified behavior analyst, and suicidologist. I am the founder of Prosper, which is the proactive reduction of suicide in populations via evidence-based research. I just wanted to share my support for the BAR model and Project Aware. These school programs dovetail with Prosper in several ways. In implementation, they complement one another by shifting culture, overcoming the limits of our current education system. They build greater capacity within the education system, foster connectedness, and create a safe, trusting environment where youths in distress can more easily seek and receive appropriate evidence-based help. I would expect a multiplicative effect of implementing BAR and Project Aware in concert with Prosper. Thank you, Chairman.
Very good questions for Dr. Corso, committee. Dr. Corso, I'd ask one favor of you. I saw your name on a flyer on an advertisement for the program going on in Pinedale. Can you just give us a brief Reader's Digest version of what that is? What is this thing that's going to be going on in the state concerning suicide prevention?
Yes, Chairman. So the events in Pinedale, which are on the 6th next week, one is an all-day training for first responders, educators, those in the faith-based community who are leaders, and frankly, anyone else who would like to attend, such as maybe a crisis worker or someone who works with a crisis line. And that is an all-day program. And then that evening, it's a community event. So the community event is for everyone, including children 12 years and older, parents, any of the aforementioned parties, and just community members at large. It's an opportunity to have a 90-minute conversation about suicide in order to destigmatize and motivate folks to be part of the solution.
Very good. Thank you. No further questions, committee? We let you off the hook and go back and go swimming.
Thank you.
Okay, committee. We covered 9:30 and we moved on up to 11:30. We're cooking. Okay. Let's move up to the 11:30 topic, which is Inseparable Mental Health Organization presentation. I believe that we have Shane Schultz to present to us on that. Correct? Come on down. And the rule here is you have to smile when you sit in these chairs. Nobody behind you knows if you're smiling or not. Well, they might. If they're looking at the screen behind us, they know. Go ahead and introduce yourself and go ahead and proceed.
Thank you, Mr. Chairman. My name is Shane Schultz. I'm with Brownstein Hyde Farber Schreck out of Cheyenne. And I'm here today with Jake Swanton, Vice President of State Government Affairs for Inseparable. I'll let Jake introduce Inseparable and himself, but again, thank you. Really appreciate the chance to brief the committee on what Inseparable is, what they're doing, how they're working around the country in various states.
Welcome, Jake.
Thank you so much, Mr. Chairman. Thanks to all of you for having me here today. My name is Jake Swanton. I'm at the national organization Inseparable, and we're working across the country to help states, policymakers, elected leaders find the right solutions to supercharge their mental health systems and improve them and provide more access to care. Next slide, please. Looks like the formatting got a little bit wonky in the transit, but 2 copies of my presentation agenda here today. I'll start with a little bit more on Inseparable. I also wanted to dig in on our most recent nationwide report, which we did on crisis services for mental health in the United States that we just released last month, or I guess it's August 1st, 2 months ago in June. And then talk a little bit about some of the solutions that we've seen around the country put into practice, some that might be a little bit more relevant or at least interesting for a state like Wyoming, and then talk a little bit about youth mental health, which I know is a big topic for you all. Next slide. Really excited to introduce our work and reintroduce it to those of you that we've already had the chance to meet with and discuss what we do. We're national nonprofit, like I mentioned, that started during COVID, so it's still relatively new in the grand scheme of things. And we're dedicated to winning better mental health, period, across the country, both at the state level and increasingly working at the federal level. We've got three main areas that we focus on today. The first one being youth mental health. That revolves many times around schools, giving schools the tools that they need to help support kids along with their families and communities, since that's where the kids are a lot. Access to care, and that's really around parity, ensuring that both private and public payers, insurance companies, are providing the access to coverage and paying for services that are necessary and medically necessary and on par with physical services. And then crisis response, which I'm excited to talk to you a little bit more about today. Next slide. So here is, well, to take a little bit of a step back, we provide a suite of services and ways to work with states and policymakers, from decades-long policy experts that we have on our team that can help with policy development and distilling policies that make sense for one state in a way that it might be different for the way other states working on it, to research, to advocacy, to the political side of things, to helping actually get good policy that's being created across the finish line and partnering with states and lawmakers to help them from the outside make that happen. And then another thing that we do is put together 3 big reports that really take a deep dive look at what's happening across the country in crisis. We have also put out a school mental health report card that looks deeply into what each state's doing on really bolstering how they're able to provide those services in schools. And then also our access report, which looks at, again, like I was mentioning, across the country, how are folks able to actually access the care that they need? So our most recent report is called A Better Response, that we just released in June, that focuses on crisis response. Next slide, please. I also want to do a quick caveat here that in my role, I focus on our legislative engagement across the country. I do have a background in mental health and healthcare, and I have a good familiarity with a lot of the work that's being done across the country. That said, my policy depth pales in comparison to the colleagues that I mentioned that have been working in mental health policy for decades. And so if I don't have an answer to any question that you might have, I'm happy to follow up with you with anything you need to dig a little bit deeper. So I mentioned the reports. We're diving into our crisis report. This is probably very familiar to folks here. It's the crisis continuum of care, making sure that there's someone to talk to, someone to respond for folks that are in a crisis, and then if they need it and their condition is severe and acute enough, that there's a safe place for them to go to get help. And we broke down different policy areas and suggestions that help support this continuum of care across these 5 policy areas that you see on the screen. We'll keep moving along. Next slide, please. Thank you.
So
Go ahead, Mr. Chairman.
I'm a little curious on the establishment of sustainable financing. How have you been approaching that as you've worked with other states? What does that look like?
On the next slide, I'll get into kind of how we've captured that at the high level, and then we can also do a kind of a deeper dive on some of the things. But
Thank you, Mr. Chairman.
along with the broader policy examples that we've seen from around the country in those 5 areas, we also did a state snapshot for all 50 states. And up on the screen there, I've got Wyoming's, and was going to talk through that. Co-Chair Larson, system financing is one of those, and I'll get to that kind of in the 3rd bucket, and we can dig a little bit deeper if that's helpful for you in the committee. The first thing that we look at across all states, and it's in the snapshots, is call center capacity for your 988 call centers. We really like to see 90% or higher. Wyoming hits it right at 90%, according to the national data that we've been able to get our hands on. And one of the things that I want to mention that is super compelling about this number is not just that you've reached the benchmark of 90%, but that 2 years ago, 3 years ago, in July of 2021, y'all had an answer rate of 50%. That's an incredibly dramatic increase in your answers and building out that capacity in state for answering the phone, being that first bucket on the continuum of care of someone to call. Moving down to the next section, which is on crisis response needs. Using an online crisis resource need calculator that was developed by McKinsey, and that includes data from national sources all around the country. I would never say that these numbers here are exactly what Wyoming needs to fill their need, but it's a really good estimate, so we can kind of know what we're working with ballpark wise. So using that
Quick question, go ahead.
yes.
So I'm curious how you come to that estimate of 11 mobile response teams, where you have them staged. And I say that as I reflect on our health delivery system as a whole, finding large geographic areas, sparse populations, a lot of miles in between. So I'm interested there.
Yeah, and if I understand your question, thank you, Chairman Larson. It's about if you've got an estimate that a state might need 11 crisis response teams, where are they responding from? Where's the infrastructure that they have as launching points? How far do they need to drive? Those sorts of factors, if I understand. And the way that the tool works as it looks at the data across the country is not just on population, but also population density and geography. So it does take into account if you've got a population of 100,000 in one state, but it's a lot smaller and denser versus another state, that you probably would need more teams so that you can cover that space and actually be able to have effective and responsive crisis services. When it comes to policy solutions for this, I know in chatting with you, the first time that we met, we talked a little bit about the really unique challenges of states like Wyoming that are not just very rural, but very frontier. And thinking about, well, it can't just be the answer is you need more because there's more miles to cover, but are there more innovative ways that we can marry some of the solutions that states around the country have with a much larger, less dense population, using technology, using telehealth, using provider expertise and resources, perhaps in a regional capacity, so that you can help support different providers in the state via telehealth from provider to provider. So there's a lot of different ways to kind of cut it. But again, this is far afield of your question, sir. I'm so sorry, but this is just kind of a look at how to think about these numbers.
The biggest smile in the room, somebody just when regionalization came up, because this is very similar in our discussion to emergency medicine in other groups. This is very similar, and she's still smiling, as a matter of fact. Go ahead.
Yeah, and Mr. Chairman, and I would just extend some sense of appreciation as you guys make these recommendations to, as you look at us, and thank you for the work you're doing. And I think that it's beneficial. I hope that you take into consideration also the structure of our services as we currently have them, because that can impact, for example, the crisis residential beds, or and how that interfaces with behavioral health redesign and some of that stuff. And so as you provide those numbers, if we can, it helps if we know that we're comparing apples with apples on the recommendations based on the way our delivery structure currently is versus just this global look or national look on how it's done around the states, if that makes sense.
It does, absolutely. Thank you, Mr. Co-Chair. This is really meant to be not a report card as much as it is, it's all semantics, a snapshot, right? It's a snapshot for you all in this room, for other policymakers in the state, and just a place to start the conversation from. So my main aim here in coming, and the reason Inseparable sent me, is to continue building relationships with you all, talk to you about the things that we do, but we can do in collaborating with you. So if there's interest in continuing the conversation on policy solutions, that's absolutely where we'd start, is what's currently happening here? What are your existing challenges? What are your capacity challenges at facilities, bed constraints, all that sorts of stuff.
Very good. We appreciate it, Corey. These are discussions that are ongoing in the state, and this is important stuff. So go ahead.
Mr.
Great.
Chairman,
Yes, Speaker Summers.
Mr. Chairman, thank you. So just remind me again, when you say needs and, you know, each of those three categories or three statements there, estimated number of mobile response teams needed, is that needed above beyond what we may have? Well, I don't know whether we have any, or is that just a matrix that's designed to figure out what a state with our density and our population would need, not necessarily what we have? I assume that's right, listening to what you've said.
Yes, Speaker Summers, that's correct. It's the latter. This is, we don't know, and there's not really great national data that's consistent across states to know exactly how many of these they already have, and many states have different definitions of these terms as well. But this is the overall estimated need based on your geography and population and density.
So, Mr. Chairman, just to follow up, I think, and maybe this would occur afterwards when if the committee were to discuss this stuff more in depth. But I am curious, you know, with what the Department of Health knows and the directors of DFS and Department of Health, do we have any of these things? Do we have any mobile response teams? What is them? For example, I don't even know what a mobile response team is. You haven't defined that. So that could be a guy, you know, an officer in a police car going out to respond to a call that has been trained in a certain way. And so I'm one, I guess, to you, what do you mean by a response team? And then two, do we have any in Wyoming? And I am very curious what our departments would say.
I'm scrolling up to the top of our report to see if we actually write out what we consider the definition for mobile response team. But I think, Speaker, you're generally, we think about it the same way as you mentioned, which is across states, the way that they define their specific state mobile crisis response teams, or they might call it something different, can vary a bit by state. But the broad way we look at it is, after there's someone to call, is there someone to respond that has an expertise or training in being able to handle, de-escalate, and capably respond to a mental health crisis? So that could be ride-alongs with law enforcement. Some states, and I believe Wyoming has worked on how can you train law enforcement officers to respond and have some level of ability and expertise in that response, or at least being able to triage it, right? To say, I've come to this home and I see what's happening here, and I know that I need to escalate this to another level of professional, whether that's using an iPad in some rural areas, telemedicine, or there's actually someone else on a higher level of scope that can respond in the mental health space. Did that answer your question, sir? Oh, whether or not y'all, my understanding, and this is not to throw her under the bus in the room, but I have had some wonderful conversations with Andy Somerville, who is it's a very gentle bus that everybody wants to be involved with. But my understanding is that there are some really promising pilots to try out different models of mobile crisis response here in the state.
I'm going to throw a lifeline here for a second. Director, anything you'd like to add to that?
Thank you, Mr. Chairman. And to Speaker Summers' questions, it's a bit of a mixed bag across the state. So in terms of mobile crisis response connected to the 988 Crisis Lifeline, those are capacities that are being investigated and built, developed in some cases. The bill that passed and authorized some funding in the previous session creates some mechanisms to be able to do that. So that's more formally connected to the 988 system. But you do have crisis response and mobile crisis response in various communities in different capacities, including law enforcement who are comprehensively CIT trained. That's not in every community, but in many, who do embed with, mental health professionals in some cases on emergency response, and have grown to that somewhat organically, sometimes in partnership with their community behavioral health centers. So happy to follow up with you offline, Speaker Summers, on where that is and where it's going, how it connects to 988 and behavioral health redesign. There's also federal certifications that are available that some providers in Wyoming have pursued, that more in the investigative and development stage, to certify as community behavioral health centers, which does require 24/7 mobile response. But that's a different kind of capacity building issue in Wyoming, given what it takes to scale that in certain areas or regions and how that could be delivered. So a long-winded way of saying, Speaker Summers, kind of a mixed bag, but we certainly do have mobile crisis response, just not comprehensively in sort of a formal definition that you might find in any of those three areas that I mentioned.
Good answer, Speaker Summers. You got more questions for us? Okay, thumbs up. Okay, Jake, go ahead and proceed, sir.
All right. Apologies, Director Johansson. Got asked that question and didn't realize I had all of the information to my right here. So on system financing, that gets to your previous question, Chairman Larson, many states have adopted a 988 phone surcharge, which is a per line per month fee used to support crisis call centers and response across the continuum of care. Currently, you might be familiar with 911 surcharge that Wyoming uses and that every state uses on phone bills to support 911 emergency response that we're all really familiar with. The 988 surcharge does the same thing, but for mental health and substance use disorder continuum of care and response. Because of the need for diversified funding streams, some states aren't able to. This isn't their preferred path. Look at a 988 phone surcharge. And so looking at what are other ways to sort of take a bite at the apple. We also note on the on the snapshot, whether or not a state is successfully applied for an enhanced Medicaid match for mobile crisis teams that's currently available through a waiver with CMS, and whether or not a state requires through parity efforts requires commercial insurance to cover mobile response and crisis stabilization services in the same manner as physical health emergency services are covered. And then finally, on system accountability, an area that Wyoming has been very active. You can see the darkened in circles on the screen there. We look at whether a state has passed 988 legislation that creates a crisis system advisory board of key stakeholders, requires coordination and information sharing with other emergency systems like 911 and other key stakeholders, requires annual reporting to the legislature on the crisis system and to the executive branch, and whether or not they require collection, analysis, and reporting of data on the crisis system so that we know what we can improve on. Next slide, please. Before I move on, I did want to emphasize again that these are just snapshots, primarily of legislative activity. Wyoming has made a lot of progress over the past few years on foundational legislation and advancements in call center response rates and sustainably financing and building out a full crisis continuum of care that effectively serves adults and also the unique needs of youth is a mountain to climb for every state in the country. And we salute the progress thus far made here in Wyoming. On the screen there, and I'm going to pick up speed a little bit so that the post-lunch sleepies don't take over the room. On the screen there are just 3 of the policy examples that I pulled from our larger report on what some other states are doing around some of the areas that we spoke about just a couple of slides ago. One area that has come up a lot more in recent months and legislative sessions is the issue of liability and the concern that some providers have, some facilities have, especially in serving youth with super acute mental health needs behavioral challenges, when they don't feel like they have the exact facility, the exact expertise on their staff to be able to serve these kiddos or adolescents, there's a lot of fear, and there can be a lot of concerns about whether or not they're protected in liability. And so we're seeing more and more states enact and push legislation to protect those providers and those facilities, like this past session in Washington. There's an example up there of Alabama's move to leverage those federal dollars and that federal match to help them have more dollars for their mobile crisis services. And then in Utah, they've done, especially this past session, they've done a lot on licensure and certification requirements across the healthcare system, and it's certainly including mental health. But they, over the past few years, have looked at how to do standardized requirements and certifications across crisis workers, those that are staffing crisis lines and on the front lines for crisis response for mental health. Next slide, please. As I mentioned, we're working in crisis, we're working in access, we're working in youth mental health. I know you've heard, you all grapple with as a body, youth mental health, how schools can be better equipped, how can they can work with communities to serve youth. So feel free to stop me if you want me to spend more time on these, but I thought I would maybe go through at a little quicker pace some of the things that we think about in working with states on youth mental health. This slide is to really just to indicate with some stats why youth mental health is important. And I know everyone in this room knows how important it is. One particular thing I wanted to mention, beyond how it impacts our communities, families, children, when we're not preventing more acute mental health conditions from growing, those end up really costing taxpayers and costing the state, whether that's because of inpatient commitment, justice system involvement, or just higher levels of state funded care that are required. And so we're really looking at a lot of different problems when we're looking for those solutions to prevent them from occurring.
Mr. Co-Chair.
Thank you. So when you talk about the mental health related emergency room visits and in this task force conversation, I think are we talking about I'm trying to think the right way to ask the question. I'm just wondering if they're acute behavioral disorders, or are we seeing like suicidal ideation? Because we lump all of those kind of into a mental health definition, and I'm just kind of curious is the breakdown that we've seen the most increase in, because we're talking about a gap here in Wyoming on kids that have high behavioral needs that we have no place to put them, that we're trying to rectify. But then we also, within our K-12 model, we're identifying these kids that maybe is less so on high behavioral needs, but more on other depression or anxiety or things of those nature. So can you refine that just a little bit for me on what that might represent?
It's both. It's all of the above when it comes to youth challenges with behavioral health, mental health. I think my guess is probably when folks are thinking about what's really taxing emergency departments is when they are needing to actually serve as a boarding facility for those youth that are having really acute behavioral health challenges and that are dangerous to themselves and families.
So follow up, Mr. Chairman, thank you. And that's really helpful, because as we're trying to address that, because you're right, we don't want them spending time in a county jail or even long-term in the hospital emergency room where they can't get their education, can't get, variety of those things. But in your organization, are we the only state grappling with that, or are you seeing any successful models on how they take care of that minority, it's a pretty small minority overall of these kids with high behavioral needs. What are they doing with them until they can find a more long-term solution? So we're looking at this transition period where we want to keep them safe. We want to have them get their education. We want to have them be stabilized on medications or medically, rather than in an alternative detrimental placement. So are we seeing success stories anywhere?
Don't have any panacea solutions, but I can talk, actually, we can skip ahead. Let me see if the next slide, I did want to talk a little bit about what we're seeing, you know, when it comes to youth mental health. A lot of people think about school-based, how schools can support kids in the community, but there's also this growing need when it comes to youth with acute mental health needs and them not having anywhere to go. I live in Colorado. That's where I grew up. Inseparable works in Colorado, along with many states. And I know that in recent years, the state has had to send about half of youth with acute care needs out of state. And for many families, they're not even able to find any state outside of Colorado that can serve them in the most heartbreaking cases. And so one of the things that Colorado has done on a pilot basis, and in this past session, passed legislation to expand that beyond pilot phase, is to take a look at what are the existing facilities in the state that already have some mental health capacity, or that could already have some mental health capacity, but might be reticent to serve youth with these highest acuity needs. Because you're right, sir, it's a very small number in the grand scheme of things, but they're incredibly costly to the system. And they're worst case scenarios for the families. And so getting a handle on how to really approach that population is a really big challenge. In Colorado, they've looked at how do you incentivize the facilities to feel like they can financially take on these cases and fill their beds with these children and with their families. How do they make sure that they have the expertise, or at least the support from providers that do have the expertise, so that they can have that real-time back and forth conversations to understand what they're experiencing in real time, and how can they begin to up-level and upskill their existing capacity for the long term. There's quite a number of elements to the pilot there that include, can we increase the per day rate to facilities for providing care to those youth, so that they're able to, unrestricted, so that they can take those funding and help with infrastructure, help with workforce costs, and then really providing them the support. And this is one of the things when we talked about, I believe the word you used was regionalization, Chairman Baldwin, or looking regionally, that one of the things Colorado is doing is saying, you know, there's a facility down in Alamosa that does not feel like, their providers don't feel like they have, they're really experienced in this space, but if they see really acute cases, they're not going to know what to do. That we've got a group of providers that really are very experienced in this space and have seen it all, that they can have those person via telemedicine or on the phone, so that they can get that support. Utah has done similar work, not exactly the same. And we have been wondering, this is not, to your question, this is not isolated to Wyoming. Everyone's facing these challenges. So is there a way, then in the West, where not every state's the same, but there are similar challenges to, say, compared to a southern state or an East Coast state, figure out how to tap into the resources and expertise that other states might have, so that y'all can share and scale some of these good ideas. This has worked fairly well in Colorado of reducing the number of out-of-state placements. And so we find that promising, and elements of it could work for other states. And I'll skip past the rest of my policy solutions here. One thing the one I did want to mention without skipping over it, in terms of financing, is one policy tool, which again is around a Medicaid waiver for the state to be able to unlock federal dollars for mental health services in schools or in partnership with schools. And what we've seen in other states, we just worked to help pass legislation in Alaska to do this past session, is that typically this has no fiscal note when states do it. And it really just allows them to draw down funding that's currently sitting on the table that they're not able to draw down until they submit a waiver and get it approved. And that can, I know in some states, they do think about how can you hire mental health professionals in that school. I know in Wyoming that there's a lot of diversity around, among school districts and counties and how they feel providing mental health services are best for their families and communities. And so looking at whether you can do school-linked partnerships to be able to draw down these Medicaid dollars, but work with existing providers in the community versus having them employed or in the school. There's different ways to attack it. And that would kind of fall into the bucket of we would love to help sit down and kind of think through what would that look like for a state like Wyoming. Next slide. I'm just gonna skip to the end here. You can go to the last slide. Thank you so much. This was just the tip of the iceberg. We work on a lot of stuff, but I feel very lucky to be here, chatting with you all. Everyone that we've talked to in the legislature in the state here is incredibly sharp on all of the things that we work on nationally in a way that is very unique and localized to Wyoming. And we would love to be a resource in any of these areas. So thank you.
Yes,
Thank you very much for that. Questions? Committee,
I just would like to add one comment, sir.
I guess we can let you go ahead.
Okay. In addition to what Jake mentioned about Mrs. Somerville, we've been having ongoing conversations and hope to be a resource for her organization. And, I think offer Inseparable's bench of resources that they have for any of you and LSO, especially if specific kind of questions come up about other states. And so please just feel free to utilize Inseparable. And it's nonpartisan. It's just trying to help find a solution and continue to work towards the mental health crisis.
I think I speak for the committee. Is that any information from other states, anything that's going on outside of Wyoming would be interesting and important to our work. Mr. Co-Chair.
Thank you. And Jake, really appreciate you being here and making the offer. We reach out to, in CSL, we reach out to other places to see what other states are doing. I would welcome further conversations with you and would invite you to meet with Director Johansson and our Department of Education, as well as Department of Family Services, and get a little better feel of the nuances in Wyoming in what part of the field we plowed thus far, because we really are looking and trying to figure out, and if there's some ideas and things that your organization can help us with, I think we're more than willing and would really appreciate any insight. And I think just having you get a little better feel. I mean, this is introductory time for you. So we invite you to learn more about what it is we're doing, and we look forward to working with you.
And I would further invite you to go, and she left the room, but the healthcare task force, the governor's health task force that's out there with Ms. Davis, that would be another important place for this conversation to take place, special subcommittee. And I know Director Johansson, he's not here so we can talk about it, but he would be happy to work with that too. So thank you again very much. No one online wishing to testify? Okay. Thank you very much, Ellen.
Thank you so much.
You can move back to the back row. Okay. We're moving. We're all the way up to 1:30 now. Yeah, we're cranking. 1:30 topic. Oh, go ahead.
Mr. Chairman, I know there's a couple of other things that are on the agenda regarding Project Aware and the recalibration. I don't know if we wanted to touch on those because there might be people here to testify about that, but I just wanted to remind you.
See lots of hands jumping forward there. That was our before lunch conversation. Yeah. Yep. Let's go back and let's talk about Aware real quick. I believe Dustin is biting at the bit to talk to us about that. Always. Why don't you go ahead and talk to us about recommendations and what you have on Aware, Dustin?
Yes. Thank you, Mr. Chairman. No PowerPoint, so everyone gets a quick PowerPoint break from me. Project Aware, we still have our final recommendation comes back to the memo that we introduced in June. That memo for Wyoming Project Aware has a total cost of $12.2 million annually for what Wyoming Project Aware would look like if we were to implement across the state. Interesting news for the committee, which I'll be able to present at a future meeting, is we've just started getting our social connectedness data back, and it's looking comparable to our functional data. So just a kind of side note update on that social connectedness looks outstanding as well for the results for the students that we're serving through the Project Aware. In total right now, we've served approximately 1,505 students since February of 2021. So just some additional data for the group to bring you up to speed from the last time we talked about Project Aware. We are actually introducing, and if I could ask Chief Maloney to come up, and we'll talk about a GRIT initiative that we've just stood up with the Wyoming Department of Education, if that's all right.
Come on up to the front row. We have a seat just for you.
Thank you, Chairman Baldwin. My name is Wanda Maloney. I am with the Department of Education, serve as the Chief Policy Officer. And so Dustin and I do have the GRIT framework, and that is a framework that the superintendent has advocated and is really looking to promote and support mental health across our K through 12 public schools. And with that, you can see GRIT standing for Gaining Resiliency. And under GRIT, Gaining Resiliency is really looking at that tier 1 support. And we know that districts have resources, but along with that, the department also has a free resource under that. The second is intervention, and those are the topics that we've discussed today, specifically talking about BAR. And Dustin has gone into great depth with Project Aware, and then care coordination or care solace would fall under all of the topics for intervention. And with that framework, in terms of intervention, the department and the superintendent would really look at Project Aware being something that could be provided to all districts across the state. And then looking to also supplement with BAR and Care Solace. And then finally, the last segment of it is training. And we know that training really impacts all of these areas, but there are several things that the department currently has in place with a suicide postvention guide, multi-tiered system of support, and then the Aware training, which is embedded with all of the Project Aware. So that's a very high level of the framework, and we're really at the draft formation of this and look forward to hearing any questions or comments at this point. Thank you.
Mr. Co-Chair.
So, Mr. Chairman, we've been, I think, this year deeply engaged in trying to develop a system of implementing and determining what the state's role in providing mental health services in K-12 model. And I think from where I've sat, there's been very good data and very good testimony from those districts that use Project Aware with the ESSER funds. And as we've looked at on the cost perspective side, this is significantly $14 million annual ask is significantly less than what we kind of threw out there last year at $125 million. looking at that. So I guess one of the questions that I have, well, I'll finish this, but I want to come back and ask the task force if there's any member that feels we've gone down the wrong road as we make a recommendation moving forward to use Project Aware. If you feel that we're making the wrong, if we've gone down the wrong road, let's have that discussion, because that's important as we then start making recommendations back to the Joint Education, Joint Appropriations Committee on structure and funding. But then we're going to get into this conversation also about a bar type program that then fills that gap that Aware doesn't have. And I think what Ms. Maloney is telling us here is that the Department of Ed, the superintendent of public instruction agrees on this approach that we have Aware, and we have to fill in this holistic approach to prevention with BAR. As we look at the cost of BAR, and all of us need to do that, look at that data, 80,000 a year per school for 3 years, 240. You know, we've got a $60 million one-time ask over 3 years. Take your breath away, right? And so then how do you eat that elephant? And I think, that's kind of was my questions this morning. And so there's some, I think that we can approach implementing BAR one bite at a time, meaning that we've got some districts now, I think 3 districts, 6 schools, if I got my number right, that are going to implement BAR. So I think my colleague on appropriations, we feel much better when we see the data. Is this thing going to work before we fully fund it? We have some conversation on where we at with these leftover ARPA dollars. Is there a way in the event that we can capture any of them, or if we get down to the deadline, because these are one-time funds and this is a one-time expense, can we capture those, or do we have to have it all at once? And I think what we've learned in my conversation with Department of Education is BAR, or we could have the contract could be between the Department of Ed and I just keep using BAR. There'd how we go through that process, but then have the ability to amend that contract if there's more funding available of this one-time funding to where we're not trying to gobble it all up in a general fund expenditure. So if you've got that contract and there's an agreement with the provider, and we'll just say BAR, that we get to December 31st and we've got this last number X million of dollars that we're saying of ARPA dollars that we have to get committed, that know that we could do that there, because then we can put that into place as something worth considering. So I think we have the ability, as you look at a $60 million ask here, okay, is to, after I've tried to digest that sum, is I just do not believe that we have to come in a supplemental budget session or even in the next standard session and make that full ask. I think that we can, and in talking to the Department of Education, we can implement Aware, then we can start implementing filling in that gap with BAR as we see the data and as we have the resources available. And if we find that the data doesn't prove it, then fine, we don't go anymore. If we do, then we can evaluate, and I think the Department of Education is looking at then how do we determine, if we've got a limited budget, how then can we focus on those schools that we feel would be best suited or that would benefit most from it. And I think that we would look to their expertise in doing that. So I don't think my co-chairman and I were recommending back to any of you that we're going to go in for an ask of 60 million, but we are saying, I think that we will be recommending that this is the type of what's the word I'm looking for, a program or to help complete this mental health in the K-12 system. And I think we have time to get it in there, and I think we have time to find the data, but I think we need to be sending a message forth on what that system looks like. And Wanda, Miss Maloney, if you or Dustin, I mean, I've kind of quizzed and I think it's really important that our Department of Education we're on the same page here. So if you're seeing that, or if I've misspoken, as we've talked about this, if there's something that you feel that our good superintendent is seeing differently, help us understand that. But I think we're going to have to start making some recommendations, some planning for at least rudimentarily, is that the right word? Implementing some of that. And, we've started with three district, 6 schools. And then what more can we do? We can figure that out one bite on the elephant at a time. So please, Mr. Chairman, if you'd correct me.
Mr. Chairman, Mr. Co-Chair, I think you summarized that very eloquently. And I do believe, as we look at supplementing with BAR, we would have to carefully determine schools that had the capacity and the willingness to take on a program and really see it through for those number of years. But I do believe that you captured the essence of what we are trying to achieve.
And I think, and I would add to that, is I think that you presented this exactly right, Mr. Co-Chair. That is that when we go to someone with an ask, the appropriators, that we're going to them with the picture of the elephant. We got this elephant, but we're not going to go after it all. We're not going to try to digest this all at once. Here's what we want to do. We want to get some data. We want to try this and get some data. But down the road, understand that we do still have this elephant, but, and as an appropriator, it makes more sense if they understand that that's where we're headed. And if data doesn't show it, we're not going to go there. We're going to let the lions eat the elephant. We're not going to deal with it. So I will ask the other committee members what they think. I know Representative Summers, Speaker Summers, go ahead, sir.
Mr. Chairman, thank you. And, I think the Project Aware, getting the funding out for it one time is a good deal. You're going to see, just like Chairman Larson said, you're going to see some results out of BAR, or you'll at least get some of it on the ground in Wyoming and better understand that. And then obviously what else is happening in 2025 is recalibration. And unless it goes much differently than in the past, there will be a consultant that will weigh in on mental health and what's needed in districts. And so I think you'll be able to see all of these things. And so I don't think you want to bite too big of an apple, because I think you want to get a picture of all of it before you make any big decisions.
Mr. Co-Chair.
Boy, Speaker Summers, thank you so much for bringing up that recalibration theme, because it's an important part for this task force to consider as we talk about that. As we got ready in preparation for our meeting in Kimmer, I reached out to our staff, Mr. Wilmarth and Ms. Heitrek, to say how is this recalibration going to go on mental health? If they've got a plan, if you talk to them and it seems or it appears as though they've got a plan, why would we waste any funds or effort now? Or is there value in us saying this is what we feel Wyoming's role is, and this is the policy and the model we'd like to follow? Would they then take that in consideration and make recommendations based somewhat on those decisions we've made? They chewed on that, come back to us and says that indeed that's what, as they've reached out to Picus, the consultant that we've used historically, there really isn't a mental health model that we can use in K-12 around. And so they'll make recommendations, but if we've developed a policy and if we've developed a direction we're trying to go, they're going to try and make recommendations that coalesce into that model that we've adopted. So I think if we can give some direction for them as they go into that recalibration, it just, it lends smoother water to paddle.
Very good. Committee members, what are your thoughts on this? Are we headed the right direction? Are we trying to go upstream against the tide, or what? What do you think? Anybody have a comment? Director?
Thank you, Mr. Chairman and Ms. Maloney. It's nice to see you. My experience is leading me toward BAR, a lot of, the engagement. And I'm looking at it from an agency perspective where there's direct service and direct interaction with the schools on very specific issues, with a specific child. But what I think BAR does is really provides that opportunity for the department and school districts to engage around a different conversation, which I think would help the whole system. So I look at BAR, I look at Project Aware, and then I think about how the two intersect. And I do think there's probably some conversation to have around that. And whether that's done through a pilot or, kind of playing it out in some of these districts to see what it is, the roles and the responsibilities are of the people that are working in Aware, the different positions that come with Aware versus the expectations of BAR, and can you mesh those? And if you could, that might lead to a less expensive model, possibly. So I do think thinking about it from a pilot perspective and looking at where those initiatives currently are and where BAR will be popping up, and especially looking at if those two intersect, what that means. But I also had a question, and the question is that the estimate is based on the uptake of every district, correct? And
yes.
And so if that is the estimate, but I would assume that districts would choose whether they participated in these activities. Is that correct? So the overall cost may not be as much as what we're seeing. We're seeing the most expensive model, but it may not be as much. Is that a fair assumption? Yeah, okay. Thank you.
Further comments, committee? Last chance. Okay, thank you very much, Ms. Lloyd. Okay, with that in mind, is there any further public comment online? And that would concern recalibration as well as the Aware project. Seeing none. Okay,
Did Andy have anything on this?
that's the next topic, actually.
Okay, because we have inseparable. Did we?
Yeah, we did inseparable.
Okay.
Yep.
Thank you.
Let's do this. It's 20 after 3 right now. Let's take a 10-minute break. Come back at 3:30, and we're gonna jump into then the liability insurance challenges. Now we're gonna get closer. Okay, back until 3. Chairman Larson hid this from me. I found it. Okay, welcome back. It's 3:30. We're only 2 hours behind schedule. We're catching up. Next topic, if you look on your agenda, will be the 1:30 topic, provider facility liability insurance challenges. So I invited everybody to come to the table because there's lots of chairs. If there's anybody else who wants to come up, please come up. Welcome Chairman Swanser to the table.
Thank you. Good to make it down here.
You look different on this side. Okay, we have several people here to present for us. You all can toss a coin, arm wrestle, whatever you want, but go ahead. I suspected insurance wanted to talk to us first. Go ahead.
Mr. Chairman, yes, we got thrown under the bus first, or pushed ahead. My name is Tana Howard. I am the Deputy Insurance Commissioner. I am joined here today with one of the department's Senior Policy and Planning Analysts, Leila Ladd. And we're here to chat about insurance and give you a little bit of an update, of some information and data that we have received from some of the facilities. We've worked with DFS over the last couple of weeks or month or so to get the contact information for some of these facilities that are having trouble obtaining insurance. And we've reached out to them and did a little bit of a survey. We have heard back from some, not all, but we have some information to share with you. So I will turn it over to Leila.
Very good. Welcome. This is a fun committee. Enjoy it.
Well, and I'm a novice, so thank you, Mr. Chairman. My name is Leila Ladd. I am the Policy and Planning Manager for the Department of Insurance, and I conducted the survey among the people that serve the youth in the behavioral health arena. We had a list from DFS, and I did hear back from several of them, and I basically surveyed them on what are your issues with insurance, who you insured by, do you have any issues being non-renewed or having issues finding insurance? And what I heard back was everyone was insured, but some had more of a difficult time than others. Some were insured by admitted markets, some were insured by excess and surplus lines. We also heard that there are several companies who will undertake these types of policies. There's not a lot, but there are some on each of those arenas. I then reached out and talked to an insurance company, underwriting and the sales divisions, and asked them what they look for in these types of facilities and professionals. And they said that while it is a hard market, meaning it's hard to get insurance, they do underwrite them. They require 3 years of claims-free status, which is a big thing in this arena. It is hard to be claims-free when you're dealing with humans in general. They said that they don't like to deal in the area of human trafficking exposure. So if they have people who are involved in that, that tends to be a red flag. They did say that the excess and surplus tends to go toward the facilities, whether they're an older facility or they're in a hail zone like Casper and Cheyenne and Laramie, which are the big population areas. That tends to put them into the excess and surplus versus the admitted lines, which makes it a higher cost, typically, not always, but typically it does. We did find that the general liability and the professional liability, there are admitted markets that will take them most of the time, again, based on what their claims history is. But we did find there are markets for this, however, fewer than the typical commercial lines or personal lines. It is a hard market and is harder to get for these clients.
Okay, very good.
Mr. Chairman.
Yes, Director.
Really appreciate those comments. I'm just curious, in the initial kind of dive into the information and what you found. General liability is one thing, of course, physical plant, protection's another thing. Did anything come up as it pertains to medical malpractice or clinical malpractice? It's another facet of this issue that in the concept we sketched out, purely a concept for the task force of what could potentially be built or modified in statute for certain providers that would partner with the state for this type of safety net clientele, where extreme behaviors are really the driving force behind damages, clinical compliance issues, potential lawsuits down the road, et cetera, medications, all of those things. So I'm curious if that had come up in any of the underwriting discussions.
Go ahead.
Thank you. And Mr. Chairman, we did ask for general liability, professional liability, medical malpractice type areas, as well as the facilities, and did not find anyone that would not take, or I don't say anyone, they didn't all take all of them, but we did find coverage for all of them.
And then, Mr. Chairman,
Go
quick
ahead, Mark.
follow-up. So then obligatory question for provider friends in the room is, and is finding that coverage then cost prohibitive? And that's what I think would really inform, especially the Department of Health on, is this juice worth the squeeze on, okay, policies can be found and not just going to Lloyd's of London and doing, cash policy, but clinical or medical malpractice professional liability is able to be purchased, but at what price that might lead to decisions operationally of who the provider, the facility can and cannot accept. So if anybody wants to address that, or we can follow up offline. Thank you.
Go ahead.
Mr. Chairman, Clark Fairbanks with the Wyoming Youth Service Association. I also have Rhonda Meyer with St. Joseph's Children's Home and Nicole Hauser with Cathedral Home here. And Andy Schwartz is online, I believe, if there are questions directly for them. But let me just touch base on a couple of those topics. So on May 16th, we had provided a handout, the Wyoming Youth Service Association, to the committee, and it really highlights that exact issue. This is an emerging issue for our providers. And when I say emerging issue, over the last 2 to 3 years, it had not historically been a grave concern for providers of maintaining and obtaining insurance. What have recently found, yes, the premiums are going up significantly, and in that handout on it, and the higher the level of care that people are providing, generally speaking, is where the premiums are increasing the highest. So residential treatment, but it's also happening at the residential group home levels. But the greatest increase last year, just in our survey, the premiums went up 76%. For providers, their liability, professional general liability combined were 1.1 million for providers. That's a significant budget impact for us, our members in that. But also why we're here is because we're the significant concern is there are so few insurance providers out there that a claim may make an entity uninsurable. 2 entities this year were within a week of having no insurance, which really creates a lot of anxiety when we're looking at what do we do with kids that are in our facilities if we can't be insured. Providers also in here talked about providers paying claims rather than, or paying damages rather than filing a claim. Because if you have a claim in the last 3 years, you may not have insurance. So it becomes that type of a situation. And so this is really an emerging problem for us. And we appreciate this committee really looking at this and trying to find, is there a way to help? And working with the insurance division to also look at it so it's not just from our perspective. And so it seems that we're seeing the same thing. Very few people, and it is from providers, it's been property insurance, hail, but also high-risk kids sometimes do significant property damage. You just knock off you say, I wouldn't say this in front of kids, but I can say it in front of you. Knock off a sprinkler head and flood a building, it can cause significant costs. And agencies then have paid, rather than file a claim, many times those insurance have all been bundled. We're seeing that those aren't happening as often, having to pick and choose professional liability versus property coverages. So those are just some of the factors, and just to be, we're trying to understand it, but also make this committee aware. It affects our ability, I think, for providers' ability, when you're looking at high-risk youth, is there a potential claim? Looking at their history, often higher acuity kids make it more risk. So it's a factor for us.
Good. Questions? No. Ms. Somerville?
Mr. Chairman, just a few comments and specifically to, I'm sorry, Andy Somerville, Executive Director for WAMSAC. I haven't been up here yet today. My apologies. To Director Johansson's questions about the special riders and the medical malpractice. So the policies that we see do have to have special riders for medical services and that medical malpractice. They are fairly costly. They don't make up a huge percentage of the cost, but they are something that has to be taken into consideration. And it's not just the cost, it's actually obtaining the actual insurance company that will braid that together to put it together. So it is certainly a factor. One example is how a facility might be able to provide those medical services. While they might be able to provide those in the house, the insurance company might say, well, we prefer you transported them over to the hospital, or the other insurance company may say vice versa. We want it in-house. We don't want you to take them to the hospital. So they work with the insurance company to mitigate that risk and put that cost. So far, right now, that it's a workable situation with those riders. There are, on the rider conversation, there are also riders that come with these policies that prohibit specific types of services. Juvenile sex offenders is a common one in this arena. For that type of high intensity residential, that's a different population. It's a different line of services. And so that's a common also conversation with obtaining these policies. I don't know if that, Director, if that helps answer your question.
Mr. Chairman.
Go ahead, Director.
Thank you, Andy. It does. And just as a refresher for the task force. So when we talk about this high needs population of 10 to 20 kids that, Director Schmidt and I and Department of Education are dealing with at any given time, those things that you mentioned that include insurance riders are exactly the kind of factors that we're talking about that are warranting a temporary placement while we continue to search for more suitable options. So sex offenders, yes. Extremely high behaviors, ASD, yes. Go down the list and they're there. So I think the question still remains, for this body and these ongoing discussions, is this a policy factor that is influencing positively or negatively, and I assume negatively, our provider community's ability to partner with the state to maybe not comprehensively, but be able to temporarily hold and treat some of these youth in these categories. And I'm not just trying to be redundant here, but I still, would love answers to those questions. And we've had good discussions about what those factors are, but this is a pretty big thing to pursue legislatively if we're talking about changing liability and malpractice for this specific population or this type of partnership. And before going down that road, I think it's warranted to know, if that were to change, utopia pie in the sky, where the state is now partnering with the provider community to cover more of that liability or cap it or limit it or reinsure it, then would that result in, more efficient and effective temporary placement of these kids per the RFI that went out last year? I think that issue still remains.
Go ahead. Go ahead, Andy.
Mr. Chairman, Director Johansson, just a little bit of follow-up to that question about is it affecting positively or negatively? I think it's negatively, but with hesitation on the provider's parts. They want to serve these children. They want to provide these services. But they find themselves in a room with risk folks and insurance folks that say, all right, let's move all these chess pieces around. How do we make this work? It is working right now. We have insurance coverage. The puzzle is still fitting together. The question remains, I think, to the point was made earlier about an emerging issue is how much worse does this get? When do we end up in front of an insurance company that says, you can't do this anymore. We're not going to insure you, and that forces that entity to drop that service line. In all of these conversations with the insurance industry, that they keep coming back to the exposure of coverage, and what does that look like? And that's that statutory cap that we've talked about, I think, in a few other pieces. But I do think, I think the message is there are absolutely providers that want to serve and they want to serve these children. We just have to figure out how to keep the pieces together, if that makes sense.
Go ahead.
Mr. Chairman, at risk of maybe taking this a little bit farther, I think I've heard, wondering, well, could we do something for these 20 kids? And I would caution that because, thinking for the agency that I retired from, served 1,200 kids a year from prevention through treatment. And many of those kids, or some of those kids were high risk, became high risk kids, but we served them and had claims. And they wouldn't have been identified as the 20 high risk at that time. So I just put that out there. The concern is it takes one claim from a kid that may not have been identified yet as the highest risk, but they're high risk. And so it's a broad issue. And I think that's we've, as a provider group, really have worked to serve these kids. And our concern is identifying, we're committed to trying to keep that number as a very small number and continuing to serve as many as we can. And this is just one of those issues. So if your question was, if we did something for those 20, and I would suggest, I don't think it's that easy. I think that there may be 100 that are high risk for claims that could close if there isn't a provider or an insurance coverage. So I realize I risk opening that up a little bit bigger, but it's for really thinking that through.
Mr. Chairman.
Go ahead, Director.
So to that point, and well taken, I think it is, obviously I'm oversimplifying it for the purposes of the 10 to 20 kids we've been talking about that we're reacting to on any given day, trying to help and create some level of care that transitions better into what a more appropriate level of care would be. So keeping it there, and again, noting your points are well taken, it is multifactorial here. So there's rates that are part of this, that the RFI was consider a blank check and say what it costs, but that can't be considered in isolation, because I think liability and insurance coverage is part of that. Geography and staffing is a huge component of it, that even with all the money in the world, there's not all the people in the world. So your points are very well taken. I think, again, from my perspective, for this task force is a decision point on, should the state explore for this population a new scheme of partnership on liability and insurance coverage for providers, or not. And I think that it's still unanswered in my mind. I think the idea is interesting and somewhat unique, and we have some other states that are pursuing similar things. So I just keep that question open-ended for the task force.
Chairman Zwanter, you had something?
Oh, yeah, simple question. When we talk about an adolescent with high behavioral needs, are they automatically considered PRTF, or can you have a high behavioral need in just a regular residential treatment facility?
Go ahead.
I think that's a great question, and I think that they could be across the continuum of care. That high need youth could come into a crisis shelter. Often a crisis shelter might be seen as a lower level of care in the continuum of care. They may then go to a group home for assessment because they need more assessment. That assessment might drive them to either residential treatment or psychiatric residential treatment. So to answer that question, I think generally we have a continuum of care with the highest needs at the highest level, but it's not, kids can move through, up and down in that continuum. And sometimes there's even respite that's provided for a high needs youth at a community level as support for a family. And so that, I think why I say that's a great question is those high needs youth can be in various levels of the continuum of care.
And Mr. Chairman, I mean, if we're going to try to figure out how to tackle this issue, it's a lot easier to say, if it's a PRTF, there are some things we can specifically do on insurance rates, et cetera. If there are high needs, kids throughout the continuum, it's a lot tougher to figure out how to cover the entire continuum. But if we can limit it, or if they ultimately do end up at some point in that continuum in a PRTF, I mean, I think there are ways to specifically direct what it might need to be on coverages, caps, insurance to those specific facilities, if that's somewhere this committee wanted to go. Thanks.
Further questions, comments?
Mr. Chairman,
Got some people online. Go ahead.
thanks. I just want to focus this topic because we've been talking about it for months, but there's no action items. And I don't anticipate that there will be. The reason for that is because I've heard that although it's not ideal and there seems to be trouble ahead, the puzzle fits together. And I think as we've discussed before, that insurance is going up for everybody, no matter what they're trying to cover, from their personal residence to their vehicles to professional liability coverage. As it relates to this issue, my understanding as to why it is on the agenda is the potential belief or the allegation that the increasing costs associated with provider facility liability insurance coverage is reducing the willingness or the ability for us to provide services to these youth. Is that correct?
Somerville.
Mr. Chairman, Senator Nethercott, it is a definite piece in the puzzle. It is not solely responsible for it, but it is an issue that has to be worked around because at the end of the day, they have to be able to keep the lights on and pay the staff. And then as it goes up, then it gets more complicated.
Nope, I get increasing costs will make it more complicated for everybody. And so then when we understand that the reason why this is on our agenda is that the increasing cost of insurance coverage may result in reduced availability of providers to provide services to our youth, then the question becomes, what type of insurance coverage are we talking about? And we continue to circle it in ambiguities as to the type of insurance coverage we're actually trying to focus in on. One is professional liability coverage for our mental health providers or medical professionals for a malpractice claim against them for providing services to these youth. I suspect that that amount of claims is very, very low. Is that correct?
Mr. Chairman, Senator Nethercott, in all of my research that I found so far, yes, very low.
Right, because this is not surgeons doing open up bodies that can leaving sponges inside, right? This is a different type of healthcare. And so the type of physical and financial damages, I think, are much harder to prove, allege, or have. So then focusing it on the two separate types of physical damages to the facilities of the providers, what we're trying to now focus in on, recognizing that the professional liability coverage, which is not ideal, and they'll drop you with one claim, but that's low and we probably can't do much about it, has to do with either hail damage, one, an act of God or some other type of understood increasing claim as a result of changing weather patterns, or two, damages caused by a youth who has a high behavioral need and does significant damage to the room, and who pays for that. So we can't fix the hail situation, obviously, otherwise the state would like to reduce our insurance costs as well as we pay for the roofs on our buildings too. And so we're all in that challenge together. But when it comes down to youth doing damage to these facilities, who does the provider go after to recover those damages? How many of those youth come from families that have homeowners insurance or homeowners insurance primarily? And are they in the state's custody at the time? So I'm looking at this from a lawyer's perspective of who has the pocket to pay.
Go ahead, sir.
Mr. Chairman, the 2 points. From our providers, 3 of the residential providers did have professional liability dropped. And so I just want to, it may not have been an active claim that caused that. It may have been other related factors, risk factors, an investigation, which is a normal process of our doing work. But the insurance company asks that on their application, and so then they drop us, drop a provider. So it is professional liability that's putting providers at risk as well.
Let's stop there.
Yeah.
I need to know the type of claim. What is the allegation? What was the claim, or what was the subject of the investigation that caused the provider to drop?
So I can speak, Mr. Chairman. I can speak from my experience when I was the executive director and had insurance. The investigation was of a child that sensitive to confidentiality. So I'm just trying to think this through before I speak. So a situation involving a suicide attempt and then an investigation, which is a normal process of what happened in that. Was there adequate staffing? Was there adequate supervision? And in that, so those are some of the situations that occur that could pose a risk for a claim.
Okay, let me just, and that might be a nuance in the insurance world. So in my world, I have business coverage insurance for things that my office can do. And then I have professional liability insurance associated with me having a professional licensure that as a result of a malpractice issue, not necessarily general negligence for failure to protect, failure to supervise, failure to properly staff. So maybe a difference there between what we're talking about for semantics associated with general negligence type claims versus professional liability claims. And the reason why that's important, and I'm distinguishing that, is under the Governmental Claims Act, which is the only precedent for any kind of financial damages cap of limitation. There's a distinction there between general liability or general negligence versus professionals, which is for lawyers and doctors and other medical professionals. But generally, that's it. So those with licensures. Then there's just 6 exceptions to the Governmental Claims Act. And that's the only thing that's capped in the state of Wyoming as far as litigation damages, which is what this insurance liability is intending to address. So I just want to distinguish that. So if there is insurance coverage that is intending to be dropped, they may or may not call it professional, and that means something different in this context, but I would say it's probably general coverage for a failure to staff as opposed to professional coverage. So let's maybe break that down too, to make sure we're all talking about the same type of challenge, problem, so we can provide the correct solution.
Please.
I think I answered the question, but if I'm missing a point, please refresh that question. Mr. Chair.
We're good? Okay, thank you. Hannah?
Mr. Chairman, Senator Nethercott, thank you for your points. I think, and to address Director Johansson as well, and some of the things that's been discussed right now, to address Senator Nethercott first, in the survey that we did, the main concern that we heard was mainly property related. Professional liability, medical professional liability has always been that issue out there that Wyoming has struggled with. And our market is in a better position, as I've told this task force the last time I visited, so I won't beat that again. But what we're experiencing with the insurance market right now is unprecedented times. Whether it's professional liability or whether it's property insurance, the market is extremely hard. And I can't make the decisions or advise to the task force of whether or not, a funding mechanism is needed. But I think it's important to just point out how the market is different than it's ever been, especially specific to property insurance in every single line of business that we're experiencing. It is the highest it's ever been. We've been having a lot of conversations with our carriers and watching the market closely, and reinsurance has leveled out slightly. So we're hoping to see premiums drop here in the next, 6 to 12 months. I'm fingers crossed. But it's a hard choice of when to step in. We're hoping it's getting better, but right now it's unlike we've ever seen.
Andy, Miss Somerville, sorry.
Mr. Chairman, just to tag on just a little bit, and I want to be crystal clear with the committee, property insurance is a huge problem, but it's not one that from our perspective, we're ready to ask the legislature to do anything about. It's property insurance. It's expensive. And to the question you asked earlier about who pays, I got to think about that. I will double check with my providers, but when I went through all of the data and information, they just took care of it. The children that are in their custody are either under DFS care sometimes, or they are coming from families that just, they don't have the ability to pay for that. And so the facility is just taking care of that. And one, to prevent a claim, two, it's $20,000 or $25,000 to fix a room that was destroyed. And they consider it part of the cost of doing business. Does that help?
Mr. Chairman,
Please.
it may not be the best course in the method of doing that business. So other businesses would not just file a claim with their insurance company over and over again, causing it to be dropped. They would, similar to the type of insurance you have with a vehicle, right? And so if the other party is uninsured, your insurance will kick in. But if the other party has insurance, including that for a minor, that insurance can cover it, including homeowners, right? So there's a number of maybe alternative pockets of money that provide coverage, not obviously in every circumstance, but probably in more than what is being addressed now in order to provide that resource.
Mr. Chairman, Senator Ellicott, I will definitely be having that conversation with my senators and follow up on that particular line. The other piece that I just wanted to kind of underscore in this conversation, I think initially when we were approached with this conversation, it was, what does it look like for insurance liability? Is that a barrier to taking these really high risk kids? And I tend to think of it more than the 10 to 15. It's a little bit larger category than that. And I think the concern that the property insurance is expensive for one of our providers, it was the primary driver of which they were dropped 2 years later. What became the problem in putting it back together was getting what I would call general liability. And I apologize for confusing the terms, but it is a general liability for the facility over the professionals and the staffing and everything. Getting that braided back in with a policy. And that's how they ended up at Lloyd's of London, and really getting in the muck to get all of those pieces put back together. But as not an insurance expert, the question came, how do we make this better? And the answer that kept coming back to me from various sources was, we need to look at a statutory cap to increase the number of insurance companies that are willing to do business in the market. Now, I can't sit here and tell you that will fix it, or in fact, if that's the best idea that's out there, but that's where the providers that are looking at providing services to this youth are coming from, is they want to be able to braid this together. It's getting more difficult. We have had some issues in the past. What do we potentially do to make that stop? So I think that I just wanted to be clear about that's the perspective that my providers have.
Thank you. And I think you got to really the crux of what our question has been to you, is not that is insurance rates going up, because indeed they are across, but are the rates for our providers going up due to the service that they provide? Is that the driver, and are they not able to get insurance because of that? And so I think we have to set aside the fact that property insurance is going up. Yes, it is, or others, but are they not able to get this general liability because of a population that they are serving, and enhanced liability that may come with that? And I think what I'm hearing is we're not seeing evidence of that. Please.
Mr. Chairman, you are correct in that we do have carriers that will underwrite and insure that type of a risk based on that alone, meaning they're not going to tell us no because this is a risk we don't take. However, I can tell you because of the hard market and the evidences of claims, especially in the human realm, they will say, we'll do this kind of an insurance until they get the application and then they decline it. One of the options that we see coming from insureds is a no isn't something that you have to take without a conversation back. And that's the recommendation from me to people that I talk to is don't be afraid to talk back to the insurance company saying, if we raise our deductible as such that we underwrite to self-insure everything below, fill in the blank, $20,000, will you relook at this? And they do have that conversation. So they will take it, but there are several things that are built into whether they will approve it for a policy.
So then does that, so if you were my insurance company and I was one of these providers that are taking kids with high behaviors, and you says, no, we don't think so. If I come back then and says, well, how about if I only take kids up to this acuity level and forego those that are on the more acute level, would you then cover me? And you say yes, because there's less, then we would conclude that it is influencing their ability to get insurance, right?
Yes, Mr. Chairman, an insurance company is more than willing to talk with someone who agrees to self-insure up to a certain point and reduce the risk on the company. It also shows, as with the homeowners, if you say, I don't consider this something that's going to get me a new roof because I want one, it's that I will pay up to a certain deductible, and they then will underwrite that and agree to issue a policy that they may have previously declined.
Well, and so task force members, we come to this conversation because the question is why do we have providers out there that won't take this more acute population? And so hence we're having the discussion, what do we do with these kids? And how do we incentivize? And the question was, well, if we went through the rebasing, we got that corrected this last session for the providers. But then we heard about this insurance concern. And it appears to me that that there's a legitimate concern or argument from our providers that are saying, well, yes, we can get insurance if we take this more acute population, but we can't afford it. And so if we reduce it down to where we can afford it, then we just can't. We're not going to self-insure the liability for that acute population. We're just not going to take them. Am I seeing that right? And so that brings us back to the conversation on the need then to have as a safety net, when we talk about what's the state role to fill that gap for those kids with high behavioral needs. Am I getting that right? Director Johansson?
Mr. Chairman, no, you're absolutely right. And this whole topic came from discussions with providers during the RFI interviews for this population that we're referring to. And maybe stupidly at this point, throwing out an idea to say, hey, would this be more feasible, more cost effective, and is it an issue with liability and insurance that is making it prohibitive to accept in this new scheme that we're talking about? Remember, we're not talking about a specific level of care. This would be a Wyoming custom temporary placement while the agencies continue to hunt for PRTFs, for RTCs, for community placement, et cetera, for these kids. And one provider, we had a detailed discussion that if there were changes on insurance, or I even threw the word out indemnification, which probably gave people heart attacks, but hypothetically, if that were the case, would that change the dynamic of provider willingness? And I don't say that with any judgment, because I don't want it to come off that, there's an anger about not being able to find, I get it. There's business decisions, and legal decisions and staffing limitations for this population. That's where this all came from. And I've heard a little bit of both sides of answers to that question, but it seems on balance, Mr. Chairman, your assumption's correct that yes, maybe there's something here. I just don't know exactly what that is and if it's worth sketching out statutory changes that are significant in capping or changing the sort of scheme for what we consider safety net providers that would be in some way covered under the Governmental Claims Act.
Mr. Chairman.
Please.
And as part of that discussion, it really was a result of the no eject, no reject policy that we were looking for in the RFI. And as we received proposals, there were these caveats that said, we will not take all. And so when we started to ask, well, what are all kids? Who are the kids that you wouldn't? That's where this very high level need of vulnerable populations, perhaps sex offenders, perhaps children who have a history of fire starting, was saying we can't take those kids because it is too cost prohibitive from an insurance point of view. And that really was then the problem solving we started thinking about. Then if that's what is getting in the way, then what levers can we pull as a state to be able to maybe address some of that, which is then how this conversation really started.
Thank you. So, Mr. Chairman, I think we're back to where we were this time last year, before we, this is a rabbit, and I don't think we went down a rabbit hole. This was just, something that come up that we felt worthy of investigation, and thank you, Anna, you guys have put a lot of work into this, but it's really helped us to see here really is where we're at. And so what then is the state's role? Is there then a need if they're not, if this is a challenge, then we need to pursue Director Johansson.
Mr. Chairman, if I can echo that to all of the providers that have engaged in these discussions with us, a sincere thank you for doing that. I know we're not at an answer yet, but the problem still remains for the health department, the Department of Family Services on, okay, what next? And we've had a lot of those discussions, and I think this is a component of it. I'm still all ears, open to ideas on whether it's with rates, insurance, liability, et cetera. What are those factors that would really influence your organizations, whether it's 2 cases or 20 cases that would better our incentives as a state to find more appropriate placement? Thank you.
Is it appetizing, and you don't have to, is there an appetite that if there was a very difficult case that would impact your insurance, that the state reimburse you for the cost of the rider to cover while that's, I throw that out there, that as we look at cost of that. So you might think on that a little bit. It's can get a rider for anything, right? Just about, Okay. Dustin?
Mr. Chairman, if I could ask a question.
Sure.
From an organizational perspective, is there, I understand that the providers want to help these highest acuity youth in need, where, I work with my health counterparts, my DFS counterparts, on the education piece of this. We have a very hard time placing students with or youth with arsonist tendencies, sexual offenders, absconding, elopement, those kind of things. But from an organizational perspective, is it more cost effective to work before you hit this upper echelon of acuity? Could market forces be a part of this equation for why why we're having a really hard time, going back to these 10, 15, 20 youth, because, it brings me back to something that Franz said a couple meetings ago, is fundamentally these systems haven't been built. There's got to be a reason why those systems haven't been built. Could market forces be one of those items from your perspective?
Mr. Chairman.
Please.
As I listen to this, we haven't come forward with a specific ask because we don't know what we need as well from our providers. I don't believe it's the premium that we're not coming to you saying, our concern is our premiums are increasing too high. What we're really concerned about is that claim that then eliminates us being able to provide services for any of the kids. And we realize we're not there. Well, we had 2 providers this year that were within a week of being there, and we have 4 of our higher level services, 4 providers that were able to go out and find 1 company. So when I think of that, and this is just me, when I think of that, if that 1 company hadn't agreed to take these 4 entities, what then? And so it's just trying to understand it better. What we don't want is to be in 6 months having 2 or 3 providers that have to close services. And though I'm not trying to be I'm trying to alarmist. Thank you. It's late in the day. Not trying to be alarmist, but those are really, I think, the biggest concern that we have in providers are having to really assess. So this child has an elopement issue, has had significant suicide attempts, maybe has had assaultive behavior. And if we put them into the population, is there a potential for a claim, a much higher potential for a claim? And that's, I think, as it relates to the general, but it also affects, for us, our general and professional liability are generally tied together by the same provider. You have a clinical professionals that are, assessing that, doing safety planning. And then on the general side, you have your direct care staff. It's generally tied to that. And I don't know that I can separate out which one is, generally those premiums for the general and professional liability are all around that professional level of services, treatment services. And it's the residential side of that. And so it was really in this conversation of saying, it's a real factor for us and we don't have the answer, but I think we've come to understand it. Certainly I have, and I think our providers are understanding it a little bit better. But that risk, 1 claim in the last 3 years, when you're looking at high needs kids, that the likelihood is pretty high that you might have a claim with the higher the kid's acuity is. Thank you.
I just tell you, Mr. Welcome to the world that I lived in 35 years doing business in construction, where there were years that people would, this isn't new to the insurance world, and it gives you great pause. So just appreciate all the work, and, we'll continue to have these conversations. Thank you.
Okay.
Mr. Chairman, back to you.
Thank you. Thank you for having that. I got a little bit of fire going on at home.
Literally.
Yeah.
Oyster Ridge?
No, this is in your relatives' end of the world.
Uh-oh, Cokeville.
Yeah. So, anybody remain online that wanted to comment on that? I know. Okay, we'll give him that opportunity. Andy Schwartz, if you wish to comment, we'll give you this opportunity. If not, close your eyes, ignore us, and we'll let you. No hand jumping in.
Mr. Chairman, thank you for the opportunity to speak. I really have nothing to add. I think there are some fundamental questions that eventually have to be answered in terms of you could view it as a small number of youths who we're discussing. And I think it's the state should be making sure that all of our youth get the care that they need. So then the question becomes, what considerations have to be made to ensure that happens? I don't have the expertise that Mr. Fairbanks has. I'm no longer on the Appropriations Committee, so I'm much more inclined to throw money at it. But I recognize that may not be the case with the legislature. But I think this conversation needs to keep going. And I will add, we are seeing a little bit more stability from insurance companies at the moment, but that's not a guarantee either. That's a market that can become extremely volatile. And I would stand for any questions.
Okay, although you didn't introduce yourself, I think we all recognize your voice.
And Mr. Chairman, I owe Andy an apologize. I was supposed to call him back and let him know what we was going to talk about on this deal, and I never did. So Andy, I really do apologize and publicly make that to you. I'll try and do better next time.
The apology is certainly accepted, Representative Larson. And Chairman Baldwin, my name is Andy Schwartz, and I represent WISA.
I assume won't take long. You've only been in for a month.
Mr. Chairman, thank you. I'll be very brief with the behavioral health redesign update. As the committee knows, this has been a multi-year effort that was ultimately legislated about 2.5 years ago. We've been in design and development phase with a launch date that was directed by statute of July 1st of this year. We have implemented behavioral health redesign. 4 big kudos I want to throw out. Number one, to our provider partners in our WAMSAC providers. Our community behavioral health centers have worked with us every step of the way to get to implementation. Staff in my director's office, behavioral health division, Matt Petrie is here today from the behavioral health division, should you have any detailed questions, and our healthcare financing division. Mr. Chairman, it's important for the task force to know one of the big lifts of this behavioral health redesign was consolidating, leveraging, and using new technology systems, primarily in what you all invested in over the last 6 or 7 years in Medicaid, what we call our WINGS project. We have combined eligibility systems for behavioral health redesign that now flow through the Medicaid technology, as well as provider enrollment system and our claims processing system. Those are usually the main issues in a big launch in the first 30, 60, and 90 days. And so on July 1st, system turns on and we see what breaks. We did have some breakages that the staff really have worked together to resolve for the most part. Still some issues going forward, but as I mentioned, we have claims coming into the system. We're paying providers in the new framework. All of the contracts have been executed, rules on the books. So a big lift, and I know I sound braggadocious here, but I have a lot of staff and our provider partners to thank for getting us here. Ultimately, the goal with prioritizing the populations we're serving with the state funds are to better serve those with the highest needs, including in our state hospital system, our judicial and law enforcement systems, our Department of Family Services system, and our correctional system. The big task over the coming months is to ramp up one portion of the behavioral health redesign, which is our outcomes payment pilot project. So we have base payments, service payments, and outcomes payments. Base payments are contracted. First one was made. Service payments, as I mentioned, are going through the system, and we and the providers are getting better on identifying the issues with billing, and those reimbursements are flowing. The big innovation of the behavioral health redesign is to pay providers directly for achieving social outcomes. And accordingly, the state hospital, the Department of Corrections, the judiciary, and the Department of Family Services nominate and refer outcomes clients for those additional service payments. That is what we anticipate ramping up over the weeks and months to come. And I'm pleased to report, although the providers might disagree, that the hunger for those clients, the real desire to reach out and try to serve state hospital clientele, try to serve Department of Corrections clientele, Department of Family Services clientele, or judiciary clientele. I very much appreciate the provider's proactive spirit in seeking those clients out, trying to get them enrolled in services and try to improve these social outcomes like housing and employment and other factors that we will pay for. So no payments have been made in the outcome system yet. I hope that changes soon. And the agencies that are working together, we have some work to do again to ramp up that the outcomes referrals and get those clients enrolled, and that's in process. So very rapid update, Mr. Chairman, but really pleased with the progress on behavioral health redesign. I think I'm cautiously optimistic that this could achieve some of the things that this committee has been expecting, and certainly the legislature expects, with showing improvements in these people's lives and reducing the stress and the recidivism in other systems like the judicial system, the law enforcement system, correctional system, family services system, and selfishly, my state hospital. So with that, Mr. Chairman, happy to answer any questions the task force has.
Questions for the director? Oh, there's one. Go ahead.
I
Director.
just had a comment, Mr. Chairman. No
Okay.
question. I'm sorry.
Go ahead.
I just wanted to discuss just very briefly the collaborative efforts with the Department of Health and our providers. Just since July 1st, we have 40 individuals in the pipeline that are going to be released from our institutions who are already signed up and getting moving forward. So they're going to be going to our ACC. So that's quite a bit. If you look at the 400 slots we were given over 2 years, we're averaging around 14 a month, and we got 40 just in the first month that are prepared to start receiving services. So it's wonderful. Thank
Good
you.
job. Good news is always welcome. Okay, no further questions for the director? None online? Good deal. Okay, we're getting close to the finish line. We're still an hour and a half behind, but it's okay. Let's move on to item 8. Oh, you're right. Yeah, I'm getting in such a hurry. I'm trying. The light's so bright at the finish line, I'm trying to get there. Okay, public comment on the director's comments on, I already forgot what we talked about, behavioral health redesign. Ms. Somerville, all the way from the back row clear to the front. Go
Thank you,
ahead,
Mr.
ma'am.
Chairman. I will be very brief. I was oscillating back there whether to come up and say anything or not, but just the providers wanted me to pass along the message. We are about 4 or 5 weeks in. There's a lot of moving parts, and we just want to encourage a lot of communication between the agencies, between the stakeholders. We've gotten a lot of questions from county attorneys, from county commissioners. That education component is going to continue to be really important. And so if you see things, you have requests, the providers just want to make sure everybody knows the door is open. Obviously, everybody has my phone number. Just we want to keep those communications going. I think we're working through some things, and we're going to keep doing that. Flexibility with outcomes clients is really important, I think, as we build that program out. So, Mr. Chairman, that's all I wanted to share.
And I would extend to you, Ms. Somerville, too, that let's keep the two-way open. If there's a concern for both labor and health and for this committee, that if there are concerns, bring that back so we can discuss it.
Yes,
down the
Mr.
road.
Chairman. You know me, I'm never shy.
It's not what I've heard. Okay. Thank you very much, Ms. Somerville. Okay, now we're going to get closer to the finish line. Let's move on to item 8 on your agenda. Consideration of bill drafts. Would somebody like to present the first bill to us on Title 25, which will actually be the only bill that we discuss today?
Thank you, Mr. Chairman. Anna Johnson, LSO. I'm going to be walking you through 25 LSO 30. This bill draft's entitled Title 25 Costs. This draft essentially shifts the burden of paying for the first 72 hours of Title 25 detentions from the applicable county to the Department of Health. Beginning on page 2, Wyoming Statute 2510-110 is amended to remove references to the costs of treatment being taken on by the county. And then Wyoming Statute 2510-112 is also amended to remove those references. Subsection E on page 4 indicates that the Department of Health will pay for the cost of Title 25 treatment subject to the provisions of the newly created subsection N, which I'll describe later. Subsections F and J on page 5 are amended to remove references to the applicable county. And then on page 6, subsection K was created to indicate that the Department of Health will pay for transportation, emergency detention, medical treatment, and any other actions taken under Wyoming Statute 2510-125A. And then the newly created M on page 7 indicates that the applicable county will pay for proceedings for detention, treatment of involuntary hospitalization, and clothing. And then the newly created N, starting at the bottom of page 7, indicates that the applicable county will repay the Department of Health at the standard rate set by the department for the costs of treatment incurred by the department during the first 72 hours of detention, including medical treatment. Section 2 on page 8 indicates that Wyoming Statute 2510-112A through C and 2510-125B are repealed, and then that repealed language is right under there in a staff comment if you want to look at it. And then on the bottom of page 10, the staff comment indicates that the task force may wish to consider whether an appropriation to the Department of Health may be necessary to pay for the additional Title 25 costs. Section 3 is an applicability section. Section 4 authorizes rulemaking by the Department of Health, and Section 5 provides a split effective date. And I would stand for any questions.
Thank you. Questions for LSO? Director? Oh,
Mr. Chairman, not a question for Anna, but just a general comment.
go ahead, sir.
So this bill, it seems interesting, the Department of Health taking over all Title 25 costs. This has been a lengthy discussion over many years, as long as I've been with the Department of Health, of whether or not this should happen, both on the financial side, but also on the administrative side. And the simple idea here, and I appreciate the way it's drafted, is that the department assumes those responsibilities for treatment, basically treatment costs, transportation as well, under the first 72 hours of Title 25, which right now is solely the financial responsibility of the counties. Then there's a subsequent provision for the state, for the Department of Health, to charge the counties for that cost. And you would ask, well, why would we do that if they're still going to pay for it? There's really two reasons. One is administrative burden, where, county offices, county attorney offices, et cetera, they don't do what we do in terms of adjudicating claims, doing HCFA 1500s on healthcare costs, et cetera. So there's an administrative burden that this lifts from the counties, because this is really Department of Health bread and butter, especially as I mentioned with behavioral health redesign. We put our Title 25 system through the Medicaid technology years ago to make that more efficient. So there are efficiencies there in just the expertise of processing and adjudicating claims from providers that would ordinarily have gone to the county. Secondly, we pay a standard rate for Title 25 in the Department of Health, and this is post 72 hours. That is either the Medicaid rate, if you have a Medicaid eligible individual that's gone through the Title 25 process, and there's hospital reimbursement rates in our Medicaid fee schedule that drive that. And for non-Medicaid clients, as it has historically been, we pay a per diem rate plus professional services. The second component of this benefit, so to speak, to the counties would be getting the department standard rate. And that's highly variable with what counties are currently being charged by providers or hospitals that treat Title 25 clients. And that can be very little, or that can be a lot. This would standardize that and creates a discussion that I think is necessary at what is the appropriate rate to pay on a per diem basis to hospital providers or other treatment providers under Title 25. So those two components, I think, are what are really operating here to try to make the system financially a bit more efficient. And then I'll mention as a side note, Mr. Chairman, that the types of providers in Title 25 do need to be differentiated. We have a few hospitals around the state that have dedicated psychiatric beds. WBI is a provider in Casper. Cheyenne Regional has some dedicated psychiatric beds. Ivinson Memorial in Laramie, and a few other pockets. That's really what generates the Title 25 per diem, is if you have a psychiatric unit or beds that we reimburse for that. For non-psychiatric hospitals who still in their emergency departments or on the floor do often hold and in some cases treat Title 25 clients while they're waiting for admission to the state hospital or a WBI, for example, where we reimburse on the Medicaid fee schedule for outpatient observation, those types of hospital services that are being provided in the time period where the individual's waiting for civil commitment to a psychiatric unit. So again, the way I read this bill is that we would take that administrative burden, set a standard rate, and then essentially charge the counties back for those costs, kind of on a post hoc basis. So my 2 cents, but happy to answer any questions.
Questions for the comments on the bill before we move to further comment? Chairman Swanser, go ahead, sir.
Couple, thanks, Mr. Chairman. One, do we have any idea on the fiscal cost? I'm not sure if that's been run yet or what it would be. Second, is there any advantage, benefit, et cetera, if the Department of Health takes it on with Medicaid funds of having a federal match that's actually going to reduce the overall cost to the state with reimbursing the counties? I mean, is there a way that we can find some more federal dollars to pay for some of the first 72 hours that we're not getting right now?
Director.
Mr. Chairman, Chairman Zwanitzer, your first question first. We have not run the fiscal note yet. We can. There's some uncertainty there on, we're not privy to arrangements that certain counties may have with other providers and how they are charged or get reimbursed for Title 25 costs. But the good news is that the data from all Title 25 civil commitments, if there's an emergency detention filed, which we call a 381 form, that we have all of that data. So we could model out, if we were going to pay at X rate, what would that gross figure be for the Department of Health costs, less what would be charged back to the counties, if that makes sense for those first 72 hours. Your second question on federal match for Medicaid clients, and it's a smaller portion of overall Title 25. Most childless adults in Wyoming are not Medicaid eligible, but we do have Medicaid eligibility in the Title 25 population, absolutely. Presumably, there could be some efficiencies there by generating 50% federal match. We would have to look into that based on that overall fiscal note. But for professional services that would be reimbursed to North Bighorn Hospital, for example, if we were to have that Medicaid eligibility up front and North Bighorn is no longer working with the county to recoup those costs, they would recoup them through Medicaid from us, and we would generate that match.
Mr. Co-Chair.
Mr. Director Johansson, it seems to me that if we're paying it and then we bill the counties back, the fiscal burden would be minimal because we're collecting back what we pay. My question, I think that Chairman Zwanitzer asked a good question, but it generated another question. If it was an individual that was Medicaid eligible and we paid that, presumably with 50% of it being Medicaid funds, but then we got repaid, is there anything that smells fishy in that equation there?
Mr. Chairman, I understand your question, and I think if this were to move forward, we would work out on the back end, what those appropriate charges from us to the counties would be, less any, federal reimbursement we received. So that's important to note. I do want to mention that it's important to also consider unintended consequences with a bill like this, because while there are hypothetical administrative and financial efficiencies for the counties, keep in mind when you standardize a system, you potentially lose some of the dynamics from counties that have worked out agreements with providers or hospitals. And now provider behavior might change because the state is paying a standardized rate, and wait lists or access could change. So I just think it's important to consider that in concert with this bill.
Yeah. Further comments, LSO, anybody on the committee, before we move on to public comment? Because I know we got a few out there waiting. Okay, let's move on to public comment. Let's hear from the county commissioners. And anybody else can make their way to the table too, because it's a long ways. Jeremiah, welcome. Go ahead, sir.
Thank you, Mr. Chairman, members of the committee. I'm Jeremiah Riemann here on behalf of the Wyoming County Commissioners Association. Appreciate your attention to this topic. I will tell you I'm in the process of collecting data on Title 25 costs for the counties. I don't have the full complement of that data for you today, but I anticipate having it for your next meeting. It'll look similar to what we've provided the Joint Judiciary Committee over the years. Mr. Chairman, what I will say is that we're largely supportive of this concept. But I want to offer just a couple of comments related to it. Director Johansson will certainly appreciate this because I often hear, I know he often hears frustration over the fact that the state seems to get a good deal and perhaps some of the counties don't. And are we footing the bill for, or at least part of the bill for the state? So there's always been this tension and frustration. And I think this legislation could help that. Alternatively, and the director kind of hit at this, I often hear from some of the counties that we understand that we're paying a little bit higher premium, but we value the provider in our community, and we understand that that's a cost we might have to bear. Now, when they say that, if they go a little bit further, a lot of them will say, we still don't know if we're getting a good deal. They just don't feel like they're the experts in that conversation, and certainly feel the department is far better positioned for that. So, Mr. Chairman, to try and balance all of these things with the legislation that we have in front of you, I started to kind of contemplate, is there anything that we could do to change this? And what I came to is the guardian ad litem model. And that's the document that I put in front of you. It's just a copy of the state statutes there. And the reason that I took to that is that it's an opt-in system. Right now, we have 22 of the 23 counties that participate, or at least the last time I checked, 22 of the 23 participate. Actually, I believe it's Goshen County that does not. Now, when they don't participate, they're fully responsible for the cost of that service. So it is opt-in, which you see in provision E of the document in front of you. But it also contains another provision, and that's in that first paragraph. And it's the second, essentially the second half of that paragraph. And that is that if a county believes that they should provide a higher rate of reimbursement to a county or to an attorney that's providing those GL services, then they can do that. They can do that through an agreement, and that additional cost is borne entirely by the county. And that's an agreement that ultimately has to be shared with the GL office at the state level so that they know that agreement sits in place. So I bring it forward as maybe a model that we could put into what we see here that might balance some of the concerns that my friends to my right and left might have about this, and as well those commissioners that again feel that responsibility to try and support the services in their community. And with that, Mr. Chairman, I'd be happy to stand for any questions.
Mr. Co-Chair.
Thank you. So Jeremiah, in essence, this would be an opt-in. We could adopt, and Anna, I'm kind of, looking if we offer that an amendment. And so this is, what we would do then is amend this to make it an opt-in for a county. And do we put a time frame or what? But am I seeing that was we just create this as an opt-in, and if they opt in, then we do it where they reimburse the Department of Health, and Department of Health pay for it. If they don't opt in, they're responsible for the first 72 hours.
Mr. Ryan.
Mr. Chairman, you could have set it up as I believe, I haven't thought a whole lot about this, but either an opt-in or an opt-out approach. I
Sure.
think either one works. Certainly, we might have to work out some parameters around that so that you're not coming in and out on a monthly basis. We don't want to add additional burden to the department, or at least that's not my intention. But yes,
Sure.
that would be the concept here.
Thank you.
Okay. Further questions for Mr. Ryan? See none? Who argued to fight next? Ms. Somerville, you're up.
Thank you, Mr. Chairman. Just a few comments on this initial draft from the providers. They're taking a closer look at it, so I imagine they might have more later. But the things that stuck out to them first was in terms of might be something we need to realize with, and this might be Department of Health. We have one crisis stabilization unit that does take the emergency detentions and the continued emergency detentions. And so we would have to make allowances for reimbursement from the state for that type of facility, because that would not be considered a psych hospital or a non-psychiatric hospital. And specifically, while a lot of those services are covered under BHR for Wyoming residents, if they are non-residents, they are not eligible for BHR payments. So we would have to figure out that dynamic and figure out how that works. There were some concerns about facilities sustainability based on rates. I don't think that'll come as a shock to anybody that I'm sharing that. If it's one rate from the state, does that disincentivize providers to step out of that space where possible? Does that leave counties with less options? Does that create some interesting dynamics there? The last piece that I want to just mention, there's a piece here I think it's a carryover from the old section on page 7. It says the county in which a person is initially detained or in which an involuntary hospitalization proceedings are brought shall pay for. That comes, I think, over from the current statute, just in a new section. But it's worth mentioning that there is oftentimes confusion, arguments over who starts a detention, who is responsible for a detention, which county, this county attorney does not want to detain this person, this county attorney does want to detain this person. And that creates a lot of issues. We have a couple of places across the state for provider groups that these titles, if they're going to go through a full involuntary, they end up, I think we all can guess which counties those are. We have counties that have less resources. There's just a really difficult dynamic in terms of resolving that. Shall we have a title, shall we not, and who gets billed for it and who pays for it. Now, as I'm reading this draft, this essentially would pull the provider out of arguing with the county and in terms of receiving payment for those services. So I speak to not as a provider issue if this draft goes forward, but just as I think it's worth recognizing for this committee, this is a really complicated process with the way we do this between counties right now. And I don't know that anything in here changes that process, but it continues to be a fight. So if the idea is to simplify payments for the providers, which is definitely appreciated, although with some, I think, further discussion, I don't know that that actually accomplishes the goal, because we may still have counties arguing over who initiated, who's responsible, who lives where. Mr. Chairman, I'd be happy to stand for any questions.
Mr. Kocher happens to have one for you.
Yeah, and so when I see your face and I associate you, so what providers are you talking about?
Ms. Somerville.
Mr. Chairman, which providers in result to the confusion?
So in this bill, the Department of Health would pay for the first 72 hours, right?
Mhm.
And then the county would reimburse them for that. And the Department of Health would pay to whomever is housing or taking care of that individual. And so when you refer to providers, or you're referring to whom, and I'm assuming it's somebody that's housing or taking, and you're saying in what provider group is that? Are we talking hospitals, or just clarify that a little?
Mr. Chairman, I'll try to answer the question. The provider specifically, I'm talking about the community mental health centers that hold these folks or the hospitals, and I only have one hospital in particular that's an example of mine. I won't speak for Josh. That's the provider group that gets caught up in the middle of all of that discussion.
Follow up, Mr. Chairman. So the community mental health providers get hung up in it how?
In terms of, so if our crisis stabilization unit is holding one of these folks, and they were transported from another county because that county doesn't have anywhere for them to go, there's oftentimes arguments between the counties. This county attorney sent them, so they think that the county where the crisis center says it's not our responsibility, it's the other county's responsibility. And so our center will bill one county for reimbursement for services and get told, no, it's actually the other county's responsibility because it's county of residence. There's just a lot of confusion in that space, and I don't know that I'm articulating that particularly well this afternoon.
Thank you, Mr. Chairman. Follow up. And so I think you are, and I've heard some of that before, but if they're titled in one county, right, then and whomever the provider is, the Department of Health would pay them. And then they're going to have to engage in that argument. Okay. And so it seems to me that this is beneficial to those providers. And I think that historically we've said that if you're going to title them in Fremont County, you're going to have to be on the hook there a little bit. If you title them in Fremont County and they're sent automatically to Natrona County and then the proceedings start there, that becomes a little bit nuanced there. And we can sort, if that's something we need to sort out, then fine. If they're a Fremont County resident, but they're visiting somebody in Natrona County and Natrona County picks them up and titles them, well, that's Natrona County. It's the county where the detention, where the proceedings are brought in, the county in which the person is initially detained pays for them. So maybe there's some clarification, but it seems to me that this would alleviate a little bit of that angst. If I'm not, and Mr. Chairman, I think maybe Director, go ahead.
Everybody wants me to be the referee, so that's the biggest benefit here. But in all seriousness, I think that just to clarify, the providers that we're generally talking about in Title 25 are hospitals and what we call designated hospitals, the psych units that I mentioned before. Now that's broader, that those aren't the only Title 25 providers, but generally speaking, you're talking about a general hospital with an emergency room or a hospital that has psych beds or a combination thereof in a community where folks might get moved. That's the bulk of Title 25 stays and reimbursements in those first 72 hours or even the first couple of weeks before someone might make it to the Wyoming State Hospital. What Ms. Somerville is referring to, which she should, is we also have community mental health centers who provide crisis beds and in some cases have been used for temporary holding of kind of pre-involuntary hospitalization, but Title 25 proceeding in individuals. And in my pie in the sky, and I know this will give Andy some anxiety, under behavioral health redesign, this is a priority population for community mental health centers. So ideally that bed capacity could be reimbursed under our outside of Title 25 under our community behavioral health redesign. But I know that there's dynamics there, especially right now in Title 25, where a county might leverage a facility for a temporary 2 or 3 day hold, and the facility, in this case, Community Mental Health Center, might seek reimbursement outside of the Department of Health contracts for behavioral health redesign. As part of a bill like this, I think we would all want to look to harmonize that as much as possible with the express intent both for hospitals, general emergency department and psych beds, as well as mental health centers who might have residential capacity, where the state's intent would be, we want to make sure that these, when that services or bed is accessed, that we are paying a reasonable rate that's covering provider costs, because these are providers that provide a service essentially for the Wyoming State Hospital. First 72 hours are happening, and voluntary commitment hasn't fully been adjudicated yet. But ultimately, if someone is involuntarily hospitalized under Title 25, they are destined for the state hospital in Evanston, and our safety net providers like WBI, Cheyenne Regional, Ivanson, some community mental health centers can play a role in providing that treatment and sometimes full stabilization and discharge prior to even needing the state hospital. So there's a mutual interest there. But just to clarify, mostly we're talking about hospitals and designated psychiatric hospitals.
Ms. Somerville.
Mr. Chairman, I would just say, much better said than I articulated before. I think that gets the point across very well. Director Johansson, I appreciate that. It is just, it's, again, as I said just a few minutes ago, behavioral health redesign is a little bit of an unknown space still. We're still pretty early in the process, and we're gonna need to work some things out to make sure that the dynamics are clear. One thing that is not in this bill, but I'll just say it for further thought, if we did ever decide to take a run at Title 25 as a whole again, is when there is concern about payment, it tends to sometimes slow down the paperwork and slow down the process for having somebody move through the Title 25 process. And from a client advocacy standpoint, that's never where we want them to be. We want those people that are in that position to receive the best support, the best care, and move through the process at a good speed. It's really important. We're literally taking somebody's civil rights away through this process. And so that's just something to keep in mind. It doesn't directly impact this bill, but I think the director articulated better what I was trying to say. So thank you.
Okay. Okay, that brings us down the table. Josh?
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. I'll be very brief. Has been alluded to, there's been a long-standing concern about rates in Title 25 and in hospitals. And to that end, I would make an offer to this committee and to Director Johansson and any other member that I can bring some of our members and our hospital leaders together to break down what our Title 25 costs are in real terms and have a good discussion about what those rates could look like that would be equitable for both the state and our facilities. So I'm happy to answer any questions, and we can pull something like that together in pretty short order, perhaps even in advance of your next meeting, to at least start that conversation. So with that, I'll stop and answer any questions.
Questions for Josh, committee?
Mr. Chairman, I think that'd be helpful though.
That's very helpful. You have that directive. Thank
Happy
you.
to do it.
Okay, let's move to the end of the table. Go ahead and introduce yourself.
Thank you. Emily Smith with Wyoming Guardianship Corporation. We provide the Substance Abuse and Mental Health Ombudsman Program for the Wyoming Department of Health. And so I'm going to speak on behalf of people who are under the Title 25 process, the clients. And I think we get a lot of we get a lot of calls and have for many years from folks where there is quibbling and confusion about who is going to pay the bill. And so do not think for a second that the clients who are affected by this, that does not roll downhill to them, because it does. We get many phone calls at our ombudsman program from clients who've received the bills for their Title 25 services because people are arguing about who's going to pay them. So I'm just here to say, I think this is a great idea, because if somebody pays it and they can quibble with Stefan about who's going to figure it out, that means the client who's already in a really tough situation, who's already, in the hospital against their will, doesn't have to be involved in the fray of quibbling about their bill for Title 25. And we think that would positively affect all the folks' mental health who are in this situation in the first place. So yay for this.
Questions, committee? No quibbling? Go ahead.
I'd just say it does seem distressing that you commit someone against their will, and then especially if they have like private insurance, all of a sudden I would say a large amount of this population, if they do have private insurance, probably have very high deductibles.
Correct.
And then insult to injury,
You get it.
you're putting people in even worse situations when they're released. All of a sudden, now they've been out of work for a week, and now they have another deductible payment of, $2,500, $5,000 hanging over them, and we're in a worse situation than we started. So,
Mr. Chairman.
He's giving me anxiety. Go ahead, Director.
It's 4:59, so I think the committee wants a little bit of a history lesson, so I'll provide that. To Chairman Zwanitzer's point, several years ago in some Title 25 amendments that were made to the statute, the legislature removed a provision in what providers had to do to seek reimbursement from the state and the county, and the legislature removed the ability to bill the patient. So it's implicit in the statute that clients should not be directly billed. However, to the good comments that were just made, that doesn't touch the area of private insurance deductibles and copays and cost sharing, which any provider, and again, I say this not to be unsympathetic, but it's part of the health insurance and healthcare system that if someone has an insurance product, that is a contract between them and their insurance carrier, and then the ability to levy, copays, deductibles, cost sharing can absolutely be there regardless of the legislature removing that component to not bill the patient directly. So essentially can't balance bill. You can't bill them for the full cost of care. We have encouraged providers, and I think most of them take this very seriously, to take the client's best interest in mind when levying cost sharing, either copays, deductibles, et cetera, in Title 25 situations. But it's a tricky issue, and I sit firmly on both sides of the fence, really, on even in involuntary commitment proceedings, if you get hit by a bus involuntarily and you go to the hospital, your cost sharing and your copays are there. I understand that it's a sensitive and emotional issue when the state is taking rights away from you and saying that you need this care, but I think it's unfair to providers to just say, well, you shouldn't ever charge cost sharing, deductibles, et cetera, for that service. So a nuanced issue for sure, but I do think this would provide some clarity around that.
Good comments. Thank you. Further questions, comments? For anyone sitting at the table, it's your last shot at them. Well, for now. Okay, thank you very much to all of you. Thank you for coming. Anyone online? No one online. I'm pretty shocked. Yeah. Okay, committee, you have before you a draft of a bill. What's your pleasure?
Move the bill.
Bill's been moved, seconded by anyone, seconded by Director Johansson. Okay, committee, let's work the bill. Let's start on page 1.
Mr. Chairman.
Go ahead, sir.
So I would just, as Anna's most familiar with that, I think that that's a reasonable opt-in, opt-out language. It's an option. I think most of our counties will take advantage of it, but I would like it to be an opt-in. But where you put that, and I'd just like to give them some discretion, the LSO staff some discretion, and craft it that way, and then we can maybe look at the bill next time, let's go ahead and work it and take the final vote at our next meeting. But my conceptual amendment would be to provide the language that counties could opt in, and upon opting in has to be for a minimum of 3 years.
LSO, Anna?
Mr. Chairman, if I could just be given a little bit of license to determine where best to put that, but I mean, I'm pretty positive I could probably put it in 110, but I'm not entirely sure that's the best place for it right off the top of my head.
That, Mr. Chairman, that was my intent, because I didn't know either, but I think let's go through some amendments, have the discussion, then we'll look at it and maybe bring it up for.
And the other movement would need to be made is that we are actually going to take the final vote next meeting on this bill and not this time.
Right.
So let's actually make that move first, do a quick vote on that.
So, Mr. Chairman, I'd move that we take the vote on this bill next meeting.
Very good. All in agreement, say aye.
Aye.
Opposed, say no. Okay, just we'll move to the next meeting. Let's go through the amendments. So that being the first amendment, giving the license to the LSO staff to put the opt-in or opt-out. So move, so second?
Second.
Okay. Question, discussion. Question on that amendment. All in favor, say aye.
Aye.
Opposed, say no. That amendment passes. Further amendments, committee. Further amendments, calling twice. Seeing none. Okay, we'll move that to the next meeting, and we'll take a final vote at the next meeting on this bill. LSO good with that?
Mr. Chairman?
Go ahead, sir.
If we could maybe ask Josh, could you, we've got, it's pretty quick turnaround time. for next meeting, but if you could get that information for us, just to where we kind of have a feel and a taste for what that looks like from your hospitals, that'd be helpful. Jeremiah, it's likewise, kind of, if you could get a feel on maybe the number of counties that feel that they wouldn't want to participate, or the number of counties that wouldn't want to participate, that'd be helpful. I don't know if that's possible. We're trying to accommodate that wish.
It is a quick turn for those that haven't looked ahead on the calendar in 3 weeks. We will be meeting again a little bit further up the road, further from my home anyway. Okay, that takes us down to directions for LSO. Mr. Co-Chair, anything comes to your mind? LSO, tell us what you've got that we've asked you to do.
Mr. Chairman, we don't have a whole lot on our list. Essentially, as far as the vulnerable adults essential service matrix, you want that updated to include what we discussed this morning, and then we'll bring it back to the next meeting and you can talk more about that. We're also supposed to reach out to YDOT regarding 5311 grants. And then as to the Title 25 bill, you just want me to incorporate that one amendment, and then we'll come back at the next meeting and discuss it further. But that's all I have.
Anna, if we could, I'd like to, on that, well, the essential services list, Director Johansson, Director Schmidt, I'd like to have you, because what I heard you saying today is once we get that refined, that language refined, then you could come back with a little clarity on how what agency and agency responsibilities, right? So we'll look at this and then have something ready for further detail. Mr. Chairman.
Okay, further directions committee. They're pointing at each other from the ends of the table. Did you know? Eric with Senator Barlow. Go ahead, sir.
Thank you, Mr. Chairman. So I apologize. I had to depart from the meeting for just a little bit and remove a reptile from the basement that my wife was very unimpressed with his existence. There was I'm not kidding. That was the call I got. There's a snake in the basement. So
traditionally, Senator Barlow, you bring those for a picture for us for the whole group.
Last name Larson?
No, so I apologize, but I missed right at the beginning of this particular section of the meeting, the treatment court pre-adjudication track. I know there was probably a quick discussion of that, but could I just hear it for myself from the committee or the chairman, what their expectations are for the next meeting?
We held off on that, Eric. There was some conversation that we think we'll take a little another stab before we present it to the committee. Bring your thoughts in on that and have that bill draft to consider at the next meeting. We didn't do any action on it at all.
Okay, thank you. If I could, Mr. Chairman, I'd just like to offer my apologies that it's not more prepared for this meeting, but as I reviewed it and then visited with the Chief Justice, Alyssa, and some others, I felt like we did need to give it some more consideration. So I think you'll have a very good product to consider at the next meeting, and I thank you for that accommodation. Thank you.
Thank you, Eric. Further words of enlightenment, wisdom? Oh, there it is. Go ahead, sir.
So for the task force members and Eric, any insight that you have here, when we're going to tour the diversion court, when our next meeting in Gillette, we're going to do that first thing and have that done. So Eric, as you ponder that, any guidance that you might have or instruction ahead of time would be helpful. And were we going to start, could we maybe start at 8? And we started at 8:30, we're going to be up there anyway. Does that give anybody heartburn if we start a little bit early? Eric, is that a problem for the diversion court people?
Mr. Chairman, I'm sure they will accommodate whatever is best for the committee. I don't know that, I'm sure it'll be accommodated quite well, Mr. Chairman.
Okay. Everybody's willing to get up at 8 and go to work?
Yeah.
Okay. Okay, that means you gotta go get coffee at 7. Okay.
Mr.
Okay,
Chairman, just,
committee. Next time
Mr. Chairman, just to be
Go ahead,
clear,
sir.
we're talking about more of a informational session for committee members, maybe for an hour, hour and a half, and then start the official meeting. Is that accurate? Or is it going to actually be part of the official meeting where the public would be involved as well?
No, it will be an informational thing for the committee members, which will be followed by our actual meeting.
Thank you, sir.
Okay. Okay, committee, with that in mind, we're gonna adjourn this meeting and go to your homes. Senator Barlow, go fight some fire. That's what I'm gonna do. When I get home in 6 hours. Thank you.